My name is Mahmoud Al-Jurf. I'm Dr. Al-Jurf from King Faisal Specialist Hospital and Research Center. It is my pleasure to welcome you for the third day of our meeting. We have excellent program ahead with very distinguished speakers who will be focusing on topics related to malignant hematology, namely multiple myeloma and lymphoid disorders. I'm sure it will give an exceptional updated information about the related topics. And I would like to take this opportunity to thank the speakers in advance, and also thank the participants for their participation. Looking forward for the program tonight.
I saw him doing some. Okay, so we are not. Shall I start?
Start, Dr. Ahmed, please.
Yes. Good afternoon, ladies and gentlemen, and good morning or good evening according to your timeline in different areas in the world. My name is Dr. Amal Al-Bihani. I'm a consultant hematologist and the Vice President of Saudi Society for Blood Disorders. And on behalf of Saudi Society for Blood Disorders, I would like to welcome you all to our annual Saudi Hematology Congress, which is being run this year as what's happening all over the world as virtual. And we are glad to have that to some extent because by having it virtual, actually we have more people who got the chance to attend this conference. We have more than 20,000 registered to this conference, and at different time, around 11,000 to 12,000 attendees at different times. It's my really a great pleasure to extend my appreciation and thank to the organizing committee, the scientific committee, and to all participants who make it and hopefully make it a successful conference. We wish everybody have a successful conference. Today is our day 3 of the Congress and day 2 of our hematologic malignancies. We will be having 2 sessions today. Each session will be moderated by a different moderator. Our first session will be it will be a great honor to present the first moderator, Dr. Amal Abdul Wahab. Dr. Amal Abdul Wahab is a consultant hematologist and bone marrow transplantation. She's executive director of Oncology Center at King Abdullah Medical City. The second session will be moderated by Dr. John Apostolios. He's a consultant hematologist and bone marrow transplant at King Fahad Hospital, Dammam. So please, Dr. Amal, I will give you the floor to introduce the first speaker.
Thank you, Dr. Amal. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. We are starting the first session of annual Saudi Hematology Congress. In spite the restriction all over the world, we are still able to communicate and share knowledge. Our first speaker, Dr. Philip Moreau, is a professor of clinical hematology and head of translational research program in hematology and oncology at the University of Hospital Nantes, France. Professor Moreau's clinical interests are focused on multiple myeloma and its treatment with high-dose therapy and novel agent. So, la parole est à vous. Welcome.
Thank you very much for this kind introduction and good afternoon. We are going to speak about how to cure myeloma patients and are we going to reach this goal of curing patients. So first of all, you can here see my disclosures. And this is the official definition of cure. In fact, curing, it means that you are no longer receiving any treatment and that your residual life expectancy will become identical to that to a population without multiple myeloma. And in fact, we don't have to receive any treatment. That's a very, very important point. Maintenance and receiving a long-term treatment is not cure at all. So this is very important to keep in mind. And when you are looking at some data, what is the residual life expectancy at the age of 65? Usually, all over the world now, the majority of the people are have a residual life expectancy of 20 years. So when you are at the age of 65 with a multiple myeloma, if you want to be cured, you have to live up to the age of 84 without any treatment. When you are looking at these are the data from the US population. The residual life expectancy at 65 years is 20 years again, and at the age of 75 years, the residual life expectancy is 12 years. So it means that if you have a multiple myeloma at the age of 75 and you want to be cured of your myeloma, you have to live up to the age of 87 without any treatment. So are we able now to reach these goals with the treatment with all options that are available? In fact, let's focus on first on patients not eligible for autologous stem cell transplantation, elderly patients, and those patients are representing 2/3 of our patients. This is the picture of the recent EHA and ESMO guidelines that were published a few weeks ago. And when you are looking at the frontline treatment for patients that are not eligible for autologous stem cell transplantation, what are the best options? What are the first options? We are proposing 3 options: VRD, bortezomib Lendex, followed by Lendex, or VNP plus daratumumab, or Lendex daratumumab. And what is the outcome, in fact? What will be the survival of those elderly patients when they are treated with these 3 options? Can we think about curing some elderly patients with these 3 options? First of all, the VRD regimen, VRD followed by Lendex, was tested in a randomized study comparing Lendex versus VRD and published by Brian Dury in The Lancet in 2017. And when the paper was first reported, you see that there is improvement in the progression-free survival with VRD in red. The median PFS is 43 months, but there is really no plateau on the PFS curve. And when you're looking at overall survival, the median OS is 75 months. So that's something like 6 years with VRD followed by Lendex and no plateau on OS curve. It means that if you are diagnosed with multiple myeloma at the age of 75, then with VRD you will be alive up to the age of 81, and then probably you are not going to be cured at all. The study was updated recently in Blood Cancer Journal, and with a longer follow-up, we have exactly the same results, in fact, indicating that the median OS is something like 6 years with VRD followed by Lendex. What about the second option that is proposed in elderly patients? That VMP, bortezomib, melphalan, and prednisone plus daratumumab, based on the results of the Alcyone study, published in the New England Journal of Medicine. VMP versus VMP Dara, followed by Dara maintenance on 700 patients. The primary endpoint was PFS. With a long follow-up, we have now these results in terms of PFS. You see with a median follow-up of more than 3 years, the hazard ratio is 0.4 in favor of VMP plus Dara. That is a very good option, but the median PFS is 3 years, 36 months. And when looking at overall survival, there is also an OS benefit with VMP Dara. So definitely, it is one of the first options that is now proposed to our patients. But you see no plateau on the overall survival curve. Nevertheless, we can anticipate that the OS will be something like 8 years in median with VMP Dara. And that's very, very important. And that's a very important progress, to my opinion. But the best combination available for elderly patients is DRD, Lendex plus daratumumab, based on the MAIA study. More than 730 patients were randomized into the study. And when the paper was published in the New England, we saw that more than 40% of the patients were older than 75 years of age. So we have here an elderly patient population. The median age was 73 into MAIA. And when looking at the PFS at the time of the first report, the median PFS was not reached. The hazard ratio is 0.56 in favor of the triplet combination. And the Lendex arm is doing very well with a median PFS of 32 months. So we can anticipate to have a very long PFS. And when focusing on patients older than 75 years, the subgroup analysis is also showing that the benefit is not restricted to the younger population of patients enrolled in that study, but that's also true for very elderly patients. You see on the right-hand side of the slide the clear benefit of DRD versus Lendex in very elderly patients. So definitely this combination is the best, to my opinion. And when we are looking at update analysis on responses and also on MRD negativity rate, you see that we have a high rate of MRD negativity with DARA Lendex. And we also have this concept of sustained MRD negativity over time. But you see that the number of patients remaining MRD negative is decreasing when we are following those patients. It means that probably all patients are going to relapse despite this very effective combination. And at ASH a few weeks ago, Dr. Kumar did update the Maya results, and with a follow-up of 4 years, we can now anticipate to have a PFS, a median PFS, that will be 55 plus, and that's the best PFS ever reported. But nevertheless, no plateau, and we can think of having median overall survival of something like 10 years when patients will receive DARA Lendex. And definitely, some patients are not going to die from multiple myeloma, but probably from other causes, such as cardiac disease, for example. It means that with DRD, we are reaching a very, very long survival, even in patients above the 75 years. And definitely, that's the best regimen available, to my opinion. But in conclusion, for patients not eligible for autologous stem cell transplantation, the cure is very unlikely, but based on the PFS data achieved with DRD, we will have for sure a significant improvement in overall survival. So what about now patients that are eligible for autologous stem cell transplantation? Younger patients, 1/3 of them. Cure means to reach the best response and to have a sustained response. And when we are looking again at the European recent ESMO guidelines published a few weeks ago, you see that we are proposing for those patients an induction that is based on the triplet VRD combination or VTD plus daratumumab, followed by stem cell transplantation, followed by lenalidomide maintenance for all patients. And when we are discussing about frontline stem cell transplantation, we are systematically proposing this strategy for younger patients, and why we are considering that in 2021, frontline stem cell transplantation is the standard of care. This is based on 3 studies, the IFM 2009, the EMN02, and the Forte study. The IFM study looked at VRD versus VRD plus stem cell transplantation, followed by 1 year maintenance in the 2 arms of the study. The progression-free survival was recently updated at ASH a few weeks ago with a very long follow-up, and definitely PFS is improved with VRD plus autologous stem cell transplantation. And interestingly, when looking at MRD negativity tested in a subgroup of patients into the study, overall survival is improved both before maintenance and after 1 year of maintenance when MRD is negative, indicating that MRD negativity is associated with a very good outcome and a better overall survival. So definitely, MRD negativity should be the goal of our treatment for young patients. So interestingly, in the study, when you are looking at arm B, VRD and stem cell transplantation and 1 year of maintenance, after a follow-up of 8 years, 1/3 of the patients did not relapse. So definitely, this is a very good platform, VRD, stem cell transplantation, 1 year of maintenance. This is the platform, in fact, when we would like to cure some patients. The second study showing that frontline stem cell transplantation is the standard of care is the EMN02 study comparing VCD and stem cell transplantation versus VCD and VMP and no stem cell transplantation up front. And with a very long follow-up, there is an overall survival benefit for patients who did receive VCD plus stem cell transplantation, as reported at ASH 2020 by Dr. Michele Cavo. When we are looking at the Forte study that was also presented at ASH recently, Carfil-Lendex, KRD, followed by stem cell transplantation in blue, was compared with KRD alone without stem cell transplantation in green. And you see that the best progression-free survival is also achieved with KRD and stem cell transplantation. So we have here the backbone, in fact, of the treatment of young patients. But how to improve on these results, since we are considering that the PFS curve is not showing any plateau? We would like to improve those results, and one way is to add a monoclonal antibody to the triplet induction in order to increase the response rate and improve the PFS. So that was the goal of the Cassiope study, and we did compare prospectively VTD 4 cycles, bortezomib, thalidomide, and dexamethasone before and 2 cycles after stem cell transplantation, with or without daratumumab, the CD38 antibody, on more than 1,000 patients. The paper was published in the Lancet, and you see that the responses are really high, and the responses are deepening over time after each step of the strategy, after induction, after stem cell transplantation, after consolidation. And the responses were really higher, much higher, in the daratumumab arm of the study. We looked at MRD negativity by flow cytometry, and the rate of MRD negativity was 64% with Dara VTD versus 44% when we looked at VTD alone. And this depth of response translated into a better progression-free survival. And you see that in this phase 3 study, the PFS data are really outstanding in the Dara arm of the study, with a hazard ratio less than 0.5. And interestingly, based on this Dara VTD PFS data, this quadruplet combination was approved by FDA, by EMA, and is used in routine in many countries all over the world. When we are focusing on patients reaching MRD negativity before maintenance, you see here the incredible results of the PFS with Dara VTD in MRD negative patients. 64% of the patients did reach MRD negativity in the Dara arm. And you see definitely that there are very, very few events. And interestingly as well, despite the use of daratumumab and the quadruplet combination, when we are looking at high-risk disease, you see standard risk in yellow with Dara VTD, and in green, high risk with Dara VTD. So definitely Dara is improving the outcome of both subgroups, standard risk and high risk as well, as compared with VTD. But we are not able to overcome the poor prognosis of high-risk cytogenetics. So for those patients with high risk, even with quadruplet treatment plus stem cell transplantation, probably we are not going to cure them. This depth of response, these PFS results are translating, although the data are not mature, into a better overall survival. There is only a trend for a better overall survival. We need a longer follow-up, but nevertheless, the hazard ratio is less than 0.5 in favor of the quadruplet combination. And you see that at 20 months, after 2 years, 97% of the patients are alive when we are using a quadruplet and stem cell transplantation. We also looked at MRD negativity after induction, after 4 cycles. And you see that with Dara VTD, more than 1/3 of the patients are reaching MRD negativity with Dara VTD versus 23% only with VTD alone. And this factor was a very important one to predict the outcome of patients. When we are looking at the multivariate analysis of prognostic factors, in fact, into the study, the treatment group is the most important prognostic factor for PFS. So receiving DARA is associated with a better PFS. But also, interestingly, reaching MRD negativity after induction and before stem cell transplantation is also a very important prognostic factor, indicating that, importantly, we should look at MRD negativity, but immediately after induction, we are able to predict the outcome when patients are MRD negative. And it's important to reach MRD negativity, not only before maintenance, but very early after induction. And this is the outcome of patients MRD negative after induction in the DARA arm of the study, and definitely that's the best arm into the study. So it is important to reach, as I mentioned, MRD negativity before maintenance, but also after induction. Why not using, instead of VTD, VRD, lenalidomide, instead of thalidomide, and adding daratumumab into this quadruplet VRD DARA that was tested as well in the randomized fashion in the Griffin study published last year, but by Dr. Voris from the US. Griffin study enrolled more than 200 patients only in the US, a prospective comparison of VRD both before and after stem cell transplantation with or without daratumumab. So the study design is very similar to that of Cassiope, but instead of using thalidomide, we are using lenalidomide. And definitely when you are looking at the MRD negativity before maintenance, MRD negativity rates with VRD DARA and stem cell transplantation, 44% of the patients as compared with 14% with VRD alone. So definitely DARA VRD is improving MRD negativity rates at the end of the consolidation and before maintenance. But to demonstrate that VRD DARA is the best regimen, and to my opinion will become standard of care in the future, we need a phase 3 randomized study. And this study is currently proposed by the European Consortium EMN. All patients are already enrolled into the study. That's a phase 3 trial. And we need a long follow-up, and we are awaiting for those very important results. Maybe we can improve not only with the addition of a monoclonal antibody during the induction part or during the consolidation part of the strategy, but maybe we can also improve on the maintenance phase. And you know that lenalidomide maintenance is standard of care, but why not using 2 drugs instead of 1? And we have some data now with a 2-drug maintenance. I showed you the design of the Griffin study, and in this phase 2 study, in the VRD arm, all patients did receive len maintenance, but in the DARA arm of the study, patients did receive the combination of lenalidomide and daratumumab, so a CD38 antibody plus len. And definitely, the responses and the quality of the response is increasing during maintenance as well, based on this 2-drug combination. You see here the PFS data and overall survival data into Griffin, and in purple you see the PFS analysis of DARA VRD, so really outstanding results as well, with more than 95% of the patients that did not relapse, in fact, with a follow-up of more than 2 years. And the sustained MRD negativity rate is also much higher when we are using during maintenance 2 drugs instead of 1. We also recently heard about the maintenance part of the Forte study that looked at KRD in the setting of stem cell transplantation. And into Forte, there was a second randomization of len maintenance for all patients versus len plus carfilzomib. So we know that there is a synergy when we are combining an IMiD plus a proteasome inhibitor. So this study was recently reported at ASH, and you see that the progression-free survival from the time of the second randomization to len alone in yellow versus len plus carfilzomib in blue, definitely there is a benefit of 2 drugs instead of 1. And this is true for all subgroups of patients. All subgroups, including patients with high-risk cytogenetics, are benefiting from 2-drug maintenance. And while carfilzomib is not probably the best agent because that's an IV drug, and we need definitely maintenance that are very convenient with len, that is an oral drug, plus maybe an oral proteasome inhibitor or a CD38 antibody sub-Q, like we can use with daratumumab. And this is the current Spanish study looking after stem cell transplantation at len alone or len plus ixazomib. We are here combining an IMiD plus an oral proteasome inhibitor, and we are awaiting for these results that will be presented potentially at the next ASH meeting. So when we want to cure patients, we need to achieve a very good response. And I show you that with a quadruplet combination, maybe with 2 agents during maintenance after stem cell transplantation, the PFS curves are very, very high. And for standard risk patients, maybe we can reach this holy grail of cure. But we need to have a sustained MRD negativity. The goal is not only to reach MRD negativity, but this has to be maintained over time. And this is the definition, the current definition of sustained MRD negativity according to the International Myeloma Working Group. Sustained MRD negative patients are patients negative in the bone marrow at 10 to the minus 5 with a confirmation minimum of 1 year apart. So sequentially, you have to assess MRD negativity with 2 different time points, 1 year apart. And this is the CML concept. You know, that's one of my patients with CML treated with Glivec. He did achieve a very good response, and he was in molecular CR. And after 5 years, when the molecular CR was maintained, we could stop Glivec, and the patient did not relapse, in fact. This is exactly the concept that we would like to reach for multiple myeloma patients. And this is the example of what was proposed into the MASTER study, a phase 2 trial reported at ASH 2 years ago. Patients were treated with a quadruplet combination, carfil, lendex, daratumumab, a very effective one. MRD was assessed after induction and after stem cell transplantation and after consolidation with 4 additional cycles of KRD Dara. And when MRD was negative twice consecutively after induction and stem cell transplantation, or after stem cell transplantation and 4 cycles of consolidation, the treatment was stopped. This is a phase 2 study. Few patients were enrolled, but when you are looking at the results after induction, 40% of the patients are reaching MRD negativity, and after stem cell transplantation, it is increasing up to 73%. So with 2 consecutive MRD negativity assessment, the treatment was stopped for 40% of the patients. And according to Dr. Costa, the paper is not yet published, but no patients did relapse when those patients were twice consecutively MRD negative. So this is an MRD-driven strategy, and that, to my opinion, is also the future of myeloma therapy. So this is the French study that we are currently running and enrolling patients. We are using a quadruplet combination with KRD and isatuximab, 6 cycles. And when patients are MRD negative, and we think that half of the patients will reach MRD negativity, patients will be randomized to no stem cell transplantation, but a very aggressive consolidation and a maintenance with a fixed duration of 3 years versus stem cell transplantation and len maintenance during 3 years. And we are going to assess each year MRD negativity and the treatment will be stopped. So maybe in arm A and arm B of the study, we will have a significant number of patients that will not relapse, and potentially they will be cured with an aggressive strategy of a quadruplet combination with or without stem cell transplantation, with a good consolidation and with a long maintenance with lenalidomide. So to conclude, I would say that for patients that are eligible for autologous stem cell transplantation, yes, we can think of curing patients in 5 years from now, especially those patients with a standard risk disease, with a quadruplet induction and stem cell transplantation, with the goal of achieving MRD negativity very early after induction, and potentially with a maintenance that will be based in the future on 2 agents instead of 1. And I thank you for your very kind attention.
Thank you very much for being on time. And now we're going to keep the question till the end of this session. I'm going to introduce our next speaker, Dr. George Cortes, who's joined Augusta University as Director of Georgia Cancer Center in Augusta, Georgia, after being at the University of Texas MD Anderson Cancer Center for 27 years, where he had many roles in Department of Leukemia Division of Cancer Medicine. Dr. Cortes has authored more than 1,000 peer-reviewed original research articles. Welcome, Dr. George. I think he's going to present through the video, and then he will be with us to answer the question.
Hello, my name is Jorge Cortes from the Georgia Cancer Center. I'm going to talk today about combination therapy for chronic myeloid leukemia. And of course, we know that the outcome of patients with chronic myeloid leukemia has increased very significantly with the use of tyrosine kinase inhibitors. Here on this slide, you can see on the left the improvement in survival at the MD Anderson Cancer Center. And then on the right, the epidemiologic data in the US. And you can see that both of them reflect a significant improvement from the 1970s when the Philadelphia chromosome was discovered to the current decade, and mostly representing in the last curve, in the most recent curve, the introduction of tyrosine kinase inhibitors. Now, it is very clear that the improvement is not the same in the epidemiologic general data from the whole of the United States. Still, we know that this improvement has come from the introduction initially from imatinib, which already gave us outstanding results, with the majority of patients achieving a complete cytogenetic response and even a major molecular response. And then with the introduction of the second generation tyrosine kinase inhibitors, dasatinib, nilotinib, and bosutinib, all these three demonstrating in randomized trials a higher rate of responses, deeper responses, earlier responses, a decrease in the rate of transformation to accelerated phase and blast phase. However, we do know that they do not improve the progression-free survival or the overall survival compared to imatinib. Now, I showed you earlier that the improvement in survival is not the same for the overall population in the United States as it is in the MD Anderson Cancer Center or in selected institutions. Why is it that we do not have all that improvement in all these places? Well, this is somewhat beyond the purpose of our presentation, and it has to do with the access to drugs, the adequate management of the patients, the monitoring, the adherence to treatment, and many other factors. But we also need to recognize that even in the best case scenario, in the clinical trials, the randomized trials that led to the approval of the second generation TKIs, you can see that by 5 years, about 40% of patients, whether they're receiving a second generation TKI or they're receiving imatinib, have discontinued therapy. So evidently, a significant number of patients are not getting the outcome that we want, either because of efficacy or because of safety. And we have the 10-year data for the NSTND trial, and this has risen up to 50% of patients. So half of the patients do not get what we want to achieve with a single agent tyrosine kinase inhibitors. In addition, one of the goals that we have now for patients with tyrosine kinase inhibitors is treatment-free remission. But if we look, the rate, the achievement of deep molecular response occurs in about 50% of the patients, sustained deep molecular response by 10 years. That is the data on the left from the NSTND. So half of the patients get to that goal, which we need for treatment discontinuation. And then when they discontinue, about half of the patients are able to maintain the treatment-free remission. So that means that about 25% of patients can successfully discontinue therapy. So again, it is a great achievement, but it is only a minority of patients who can get there. And we know that this is because the tyrosine kinase inhibitors cannot eradicate the leukemic stem cell. This is data that goes back several years, initially from Tessa Holyoka, and many others since then, showing that these early stem cells are quiescent and therefore insensitive to the effect of the tyrosine kinase inhibitors. So if we look at it in a different way, the bulk of the cellular population, the cells that are proliferating are very sensitive to the tyrosine kinase inhibitors. But the earlier progenitors are not sensitive because they are quiescent, they are not replicating. So with all of these background, what are the potential uses of combination therapy in chronic myeloid leukemia? Well, we could decrease the failure rate because some patients in the front line and even more in the second and third and fourth line of therapy experience failure to therapy. We also could improve the rate of deep molecular responses. I showed you that the sustained rate is only 50%. We also want to discontinue the relapse rate after discontinuation, another 50%. Ultimately, what we want is to eradicate the disease so patients don't transform to the advanced phases, so that everybody could discontinue therapy, etc. And talking about advanced phases, the outcome there is clearly not as good as we have in the chronic phase. And more recently, we're learning of the molecular complexity of CML, where even at the time of diagnosis, many patients, up to 25% of patients, may have additional molecular abnormalities in other cancer-related genes, such as ASXL and RUNX1, etc. So what other targets can we approach in chronic myeloid leukemia for use in combination therapy? And this is a cartoon of some recent manuscript that's a very good overview by Ravi Bhatia, looking at the different targets that communicate with BCR-ABL and that lead to the proliferation of the cell, the survival of the early progenitors. Some of them have made it to the clinical trials, and we know that these different targets may lead to resistance and the persistence of that leukemic stem cell. Let's look at some of the data in vitro. This is with interferon, perhaps one of the drugs that we know the best because we've used it so much in chronic myeloid leukemia. And there is some in vitro data suggesting that the use of interferon may bring those leukemic stem cells from that quiescent state into a cycling state, which then makes them sensitive to the use of tyrosine kinase inhibitors. That is the concept behind some combination studies of tyrosine kinase inhibitors with interferon, such as this one from Germany called the TIGER study, where newly diagnosed patients are randomized to receive either nilotinib alone or nilotinib plus pegylated interferon. Curiously, after 24 months of MMR, the single agent arm continues nilotinib, the combination arm discontinues nilotinib and continues with interferon, and then ultimately leads to discontinuation of all therapy. But when you look at the results, you can see that although with the combination, you can get a slightly faster response in MMR and MR4 and MR4.5, ultimately you get to the exact same point. So it really doesn't improve our ability to get to these deeper molecular responses. There is another study, this one coming from Australia, also for newly diagnosed patients with chronic myeloid leukemia. This is a single-arm study, phase 2. Everybody gets nilotinib at the beginning. After 3 months, patients get added a pegylated interferon 2A. And you can see here that the MR 4.5 rate looks very good. At 12 months is almost 34%. And by 24 months, it reaches 50%, whereas the MMR rate is 78% at 12 months. This looks very good, but when you put it in the context of what we know with single agent nilotinib from other studies, from the randomized studies or the MD Anderson study or the GMEMA study, these rates of the deeper molecular responses at 24 months, the MR 4.5, they do not look that much different than what we can achieve with single agent dasatinib or nilotinib at the MD Anderson. So it doesn't look like the combination has achieved much. Now, we need to see if in the long term, it will decrease the rate of relapse after treatment discontinuation. That data is not yet available. In trying to improve the rate of the deep molecular responses, one of the options that has been investigated is to switch patients who are on imatinib and switch them to nilotinib. And in this randomized study called the NS-CMR, that was the endpoint, that was the goal. And it was clear that the rate of CMR at 24 months increased with the switch to nilotinib compared to continuation with imatinib. But that came at a cost with a higher rate of adverse events, particularly arterio-occlusive events, which was 6-fold higher for the patients who received nilotinib instead of imatinib. So an alternative approach is that for those patients who are doing well on imatinib, but not quite with the deep molecular response, add a combination at that point with another drug. And this is just a partial list of some of the studies that are currently ongoing. Well, let me show you a little bit of data. This is one study that we did at the MD Anderson, adding ruxolitinib. And as you can see, there was really very little benefit that we could see on these patients. Most of these patients remained with the same levels of transcripts after the addition of ruxolitinib. And this was based on the dependence of JAK2 for these leukemic stem cells. We did another study where we added azacitidine, and this one looked a little bit more promising. We had 3 patients, and all of them had a significant decline in the transcripts. However, azacitidine is a complex administration, intravenous or subcutaneous, and patients were not very keen on receiving that. Whether that will change with the oral availability now of hypomethylating agents, it may be a more practical approach that perhaps is worth considering. Venetoclax is a very interesting drug because these earlier progenitors are also very dependent on BCL2, and there is in vitro data that I'm showing you here that the combination of in this case, nilotinib with a BCL2 inhibitor similar to venetoclax leads to increased apoptosis of these earlier progenitors, particularly important even those that are quiescent. So combinations with venetoclax and the tyrosine kinase inhibitor are currently being explored, but we don't have really data at this moment. Of course, we'll have to see what happens with the increased myelosuppression or other adverse events. Asciminib is a very interesting drug. It's a tyrosine kinase inhibitor, but it binds to a very different area. It's what we call a STAMP inhibitor. It's a first-in-class, specifically targeting the able myristoyl pocket, which is distant from the ATP binding pocket where all of the other inhibitors bind. And we have seen remarkable data of this drug in patients who have experienced failure to 2 or 3 pyrotyrosine kinase inhibitors, confirmed on a randomized trial recently shown at ASH, and also very effective against T359. But importantly for this discussion is the fact that animal studies have shown that when you combine the two drugs, a traditional tyrosine kinase inhibitors, in this case nilotinib, with asciminib or ABL001, you completely prevent the emergence of resistant clones in this xenograft study. So there have been attempts at combining these two drugs. There has been, this is the original phase 1 study that included combination arms, and there was a combination with imatinib. This was for patients refractory or relapsed to prior therapies, and it showed the good probability of response. You see here almost 60% complete cytogenetic response, and MMR by 1 year of about 42%. There were also arms in combination with nilotinib and with dasatinib, and these also led to very good responses. Again, these are patients refractory or relapsed prior therapy. With nilotinib, you see complete cytogenetic response in 2/3 of the patients, MMR in about 1/3 of the patients, and with dasatinib, the same thing, an MMR rate of 36%. But more important is that these combinations are being tested to deepen the molecular response. So there has been a study for patients who have been receiving imatinib and have a good response, but not quite the deepest molecular response. And they are then randomized to either continue on imatinib, switch to nilotinib, or to add asciminib to the imatinib. And a similar concept that we started at the MD Anderson for patients on dasatinib, nilotinib, or bosutinib, and exploring the combination, adding asciminib, again, patients who are doing well, complete cytogenetic response, but not deep molecular response, to see if that can help, number one, achieve a deep molecular response, and number two, decrease the rate of relapse after treatment discontinuation. Let me switch gears to a place where the combinations are much better established, and that is for the blast phase. We know that the outcome for patients on blast phase is very poor. Even for in the era of the tyrosine kinase inhibitors, the outcome is very poor. Some responses, but these are not durable. And in the end, the overall response and overall survival is very short. However, as you can see on these curves on the right, the survival is better for patients who receive TKI plus chemotherapy, and this is any TKI with any chemotherapy. This is just a general, but that the combination improves the survival, the failure-free survival, and the response rate compared to the use of a TKI alone or a chemotherapy alone arm. So the combinations are suggestive of providing benefit in this context. We have explored a number of different combinations. This was the first one we attempted. This is many years ago. And we used low-dose cytarabine in combination with either rubicin and imatinib. Small study, only 19 patients, but we did get some good responses. The advantage of this regimen is that it is very well tolerated. Now, because this is an old study, we used imatinib, it is likely that combining low-dose cytarabine with a more potent tyrosine kinase inhibitor, a second or perhaps better, a third generation TKI such as ponatinib would give us better results. We also tried something similar with homohorintinin or romacetaxine. This regimen can be more myelosuppressive, but you can see here that you can achieve good responses in some patients. Again, this is a small study, but it does suggest the benefit of this potential combination. More recently, we just published a study combining a hypomethylating agent, in this case, decitabine, with dasatinib. This had a phase 1 component and then an expansion component, and it included patients in the blast phase, accelerated phase, or Philadelphia positive AML. And if you can look at the bottom here, you can see that there was a good response rate with a overall 19 of the 27 patients achieving some hematologic response. Half of them was actually a complete hematologic response, which is very welcome. But not only that, we did get some patients achieving complete cytogenetic response. You see here, 12 patients achieved a major cytogenetic response, and even 9 patients achieved an MMR or an MR 4.5. So a combination that could be beneficial. And you see here the hematologic response duration, the overall survival. Now, we do want to transplant these patients, and that was the preferred outcome after they achieved a response. But achieving high levels of response with a regimen with very low toxicity is certainly very welcome for that principle. Our colleagues from the Hammersmith did a different approach. They used a combination of a more intensive regimen, FLAG-IDA, with ponatinib, and you can see the schema here. I'm not going to go into much of the details, very standard regimens, but they reported a high response rate of 69%, and you can see here the overall survival of 47%. Notice there is not much of a plateau. Not everybody received a transplant. About half of the patients did, and certainly that is what you want to do in this context. In lymphoid disease, we have combined TKIs with hyperCVAD. We published this a few years ago. You can see there seems to be a better outcome in lymphoid diseases. 90% of patients achieved a complete hematologic response. However, the responses tend not to be very durable. They're better, of course, if you do a transplant, and they are better if you combine it with dasatinib. And recently, there was an update of this publication, of this approach, combining hyperCVAD specifically with dasatinib. And you can see here, both for Philadelphia positive ALL and lymphoblast phase, you get better than you would get with single agent, although still this needs to be improved. And the outcome is better if the patients achieve MRD negativity after the regimen. So in summary, there is some in vitro synergy of tyrosine kinase inhibitors with many drugs, some even chemotherapy, but more attractively, some of the targeted agents. How we're going to choose them remains to be seen. Some of the early studies, particularly with interferon, where we have more data, they have been, in my opinion, somewhat disappointing. We'll have to see if it helps for the duration of treatment discontinuation, which is perhaps where the benefit may be mostly seen in the chronic phase. In the blast phase, certainly combination is the way to go, but the combinations that we've explored to date have still much improvement to be made. So to conclude, I'm going to finish with this phrase from Karl Popper that said, "Our knowledge can only be finite, while our ignorance must be necessarily infinite." Our ignorance in this area is still very, very large. So these are my disclosures. And with this, I conclude, and I thank you for your attention.
Thank you, Professor, for this recording, and looking forward to see you in the platform again.
Yeah, so tomorrow, hello, my name is Jorge Cortez from the Georgia Cancer Center. I'm going to talk to
yourself. Okay. You can hear me?
Yes.
Dr. Wilma is a director of, executive medical director for leukemia, lymphoma, and executive, and sorry, in stem cell transplantation. In MD Anderson Cancer Center in Houston, his research focus is identifying immunology and immunotherapy strategies for hematological malignancy, particularly chronic lymphocytic leukemia. He's a worldwide figure in CLL, and today Dr. William will speak about are we reaching a cure in CLL? Please, Dr. William, go ahead.
Thank you very much. Can you hear me? Are you able to hear me?
Yes, we can hear you. We can see the slides as well.
Perfect. Okay. Thank you very much. Thank you to the Saudi Society for Blood Disorders for this opportunity to speak to you about chronic lymphocytic leukemia. And my topic, as mentioned, is are we sitting on a cure for CLL? There we go. This is a topic that is, I'm grateful to be given this topic and to sort of review the data in the perspective of working towards a curative strategy. This is sort of a new approach in terms of having a discussion. Usually we talk about what are standards of care and how are our treatments progressing, but this talk and organizing for this talk gave me an opportunity to step back and say, okay, where are we for cure? We talk more and more about cure. We have regimens that we think are working towards a cure. And so it's nice to put that concept in perspective with the treatments that we have. A couple of thoughts on cure and how we define cure I highlight in this slide. I think people think in the purest sense of the word, cure would be complete eradication of the leukemia clone, never to return, and patients having a normal lifespan for most of the patients who are receiving a particular treatment. Today, that may be the case with FCR and for patients with a mutated IGHV gene. We have long enough follow-up from those patients to say that there are a number of those patients, about 50% of them, who remain MRD negative with many years of follow-up, 10, 15 years of follow-up. Those patients may be cured by this definition, but I think there are also other concepts of cure that we're working towards and we should think about, particularly for CLL, because CLL, as you know, is a disease in the older population. That patients may get treatment, may remain in remission for long enough period that something else, they will die of something else, natural causes, and their CLL may not be what shortens their lifespan. So another concept to address here is remission with no future need for treatment and a normal lifespan. The clone in this case may be persistent, but doesn't require treatment. And then finally, patients, and I think we're here now, patients may have a normal lifespan despite needing treatment and despite maybe not getting rid of every clone, and patients going through a series of treatment. And as I mentioned, right now my perspective and my thought is that we're probably here for most of the patients, particularly those over 65 years of age, because we have now very effective targeted therapies, and we're working on combinations of targeted therapies. As you probably all know, the evolution of treatment has been, I think, remarkable for CLL. This slide just summarizes the evolution and agents that we've had available, moving from chemotherapy through combined chemotherapy to chemoimmunotherapy to targeted therapy, which is monotherapy, and now we're in an era of combined targeted therapy where we're combining our agents that work on different targets and achieving a very high proportion of patients who are undetectable in terms of MRD. We don't yet have the sufficient follow-up to say that those patients are cured, but I do think that that will come with further follow-up. We've had a number of agents that have become available for treatment for our patients, and this categorizes them according to how they to their mechanism of action. Most remarkable has been the recent inhibitors of the B-cell receptor signaling pathway, particularly BTK, and BCL2, particularly venetoclax. So a few concepts in terms of goals of care. As I mentioned, potentially curative therapy, as I defined it in the first slide, with FCR in patients who have a mutated immunoglobulin gene. Allogeneic stem cell transplant may offer cure for some patients. Most of these patients are older. Most of them have comorbidities. With chemotherapy, this used to be a bigger issue. It still is somewhat of an issue, but older patients don't tolerate treatments well, whether we're talking about chemotherapy, which is the clearest example. Also, with targeted therapy, we do see more toxicities associated with treatment. So in terms of our goals of care, we think of goals for patients in the frontline setting and goals in the relapsed setting. The first line setting is the best opportunity to achieve the deepest remission. And it's also the best opportunity to get the longest duration of response if we're talking about continuous therapy. So the two approaches right now with targeted therapy are continuous treatment, which is extremely good and effective, but patients need to remain on treatment. That's with the BTK inhibitor-based therapy. The alternative is fixed duration treatment, and that we have an opportunity to achieve with venetoclax-based therapy, where we're able to see very deep remissions with venetoclax plus obinutuzumab as a standard treatment. And then we consider retreatment at relapse, particularly retreatment with BCL2, and we can move to a BTK inhibitor subsequently for those patients if they become refractory to a BCL2 inhibitor. Goals of treatment for relapse disease really are to have long-term disease control and management of patients with the objective for them to live a normal lifespan and not die from their CLL. There are factors that I test for, particularly for patients who need treatment, that I need to know because we still have high-risk patients among those who get targeted therapy. It's important to check FISH and particularly to test for 17p deletion and for mutated TP53. Those patients, as you'll see, are in a higher risk category. And I also like to know what the IGHV mutation status is because I have different expectations for those patients, even with the newer targeted therapies, particularly with venetoclax-based therapy, where we're talking about a deep remission and time off treatment. So I test these three factors routinely when I'm thinking about a patient who needs first-line therapy. Now, there are a number of trials that have been published recently, and we have a long-term follow-up from BTK inhibitor-based treatment, shorter follow-up for CLL14. But if I start thinking about these in terms of curative strategies, I'm going to reverse sort of the order in terms of how I talk about them. BCL2 inhibitor, venetoclax, I'll start with because that's the best opportunity to achieve a deep remission and get patients off treatment. And some of those patients may be cured by the definitions that I spoke about earlier. These studies are all phase 3 studies summarized here. The first 5 are BTK inhibitor-based first-line therapies. All of them were positive, showing longer progression-free survival with BTK inhibitor-based therapy compared to chemoimmunotherapy. And then the last one on the list there is CLL14. That showed an improved progression-free survival with venetoclax obinutuzumab compared to chlorambucil obinutuzumab. These studies, all phase 3 studies, I think bring in the era of targeted therapy and make chemotherapy, chemoimmunotherapy, obsolete. Because we get toxicity with chemoimmunotherapy, we're able to achieve very, very good remissions, very durable disease control with targeted therapy, and it's much better tolerated than chemoimmunotherapy. My standard approach is summarized here in terms of frontline treatments. And I think about patients who have 17p deletion differently. Those patients, I think we need to right now put on a BTK inhibitor to control their disease long term. I'm in favor of a BTK inhibitor for those patients over a BCL2 inhibitor because while I think we can get these patients in remission, I worry about their disease if they're not on continuous treatment. Their disease, I cannot trust to turn my back on their disease, and I feel like I need to have them on some type of maintenance. So 17p deletion, mutated TP53, BTK inhibitor. For everybody else, I like fixed duration treatment, whether they have an unmutated or a mutated immunoglobulin gene. Most of those patients we can get in a deep remission. And we know if we get them MRD negative, they'll have a long progression-free survival. Some may never need treatment again. Some may need treatment, and we can go back to the BCL2 inhibitor fixed duration treatment to retreat if they have relapsed disease. And then we can move on to a BTK inhibitor if needed. So I'm going to walk through several trials that highlight and show you some of the important features in terms of the progression-free survival and overall survival with these targeted therapies. So the CLL14 trial I mentioned, I want to start with. There was an update from ASH this year for this study. It's a phase 3 randomized study of venetoclax obinutuzumab versus chlorambucil obinutuzumab showing improved progression-free survival with venetoclax-based therapy. The 4-year update is shown here, and you can see the 4-year progression-free survival rate of 74% is favorable over the 35% 4-year progression-free survival seen with chemoimmunotherapy. So very long, durable remissions. No difference yet in overall survival, but you can see an extremely good 4-year overall survival at 85% for venetoclax obinutuzumab. The venetoclax-based therapy is associated with a very deep remission, as I mentioned. That's highlighted here in the MRD data. On the left, you can see for venetoclax obinutuzumab, about 75% of the patients achieving undetectable MRD if you use 10 to the -4th as your sensitivity. This is in blood, and that compares very favorably to what's seen with chlorambucil-based treatment, which was 32%. And I should also point out that 40% of the patients who got venetoclax-based therapy were undetectable if you use a higher sensitivity of 10 to the -6th. And those are the patients who do extremely well in terms of progression-free survival and have improved long-term outcomes. So just going back here to reiterate the blue curve, which is the progression-free survival curve with venetoclax-based therapy. This is 1 year of venetoclax with 6 cycles of obinutuzumab. If you move forward to BTK inhibitor-based therapy, this is the progression-free survival curve we see with continuous treatment with ibrutinib in the RESONATE-2 trial in the gold curve. So you can see a very good disease control and long-term progression-free survival with ibrutinib-based therapy. It's consistent and similar with what we've seen with venetoclax-based therapy, but these patients require continuous treatment, and you don't get patients to an undetectable MRD status, which we think is important. I think is important for a number of reasons. In terms of risk factors and who we define as high risk, we used to think of 11q deleted patients as high risk. That's not the case with ibrutinib-based therapy. As you can see on the left in the gold curve, the patients who get ibrutinib who have an 11q deletion look like they do a bit better than patients who don't have an 11q in the purple curve who are treated with ibrutinib. Also, we used to think of unmutated immunoglobulin gene as a high-risk feature. On the right, you can see patients do equally well whether or not they have a mutated or unmutated IGHV gene with ibrutinib-based therapy. 17p, though, we do think of as a high risk, and this slide summarizes data from the NIH group that shows a 6-year progression-free survival for 17p deleted or mutated TP53 at 61%. And among those patients, it appears that immunoglobulin mutation status may help also identify even higher risk patients if they have an unmutated immunoglobulin gene. Those are the patients in red. So that requires ibrutinib-based therapy. Acalabrutinib-based therapy requires continuous treatment until progression. Venetoclax we can treat for a year. and they can have several years off treatment with a deep remission. We were interested many years ago on combining these agents because they work on different targets and they have non-overlapping toxicities. So we developed at MD Anderson a trial of ibrutinib venetoclax. We've published that data. We see about a 75% undetectable MRD rate in the bone marrow with 2 years of combined therapy. At ASH, I presented a trial that's referred to as the Captivate trial. This was a phase 2 randomized trial for patients who achieved an undetectable MRD status at the end of 12 cycles of combined ibrutinib plus venetoclax. And the goal of this randomization was to determine whether or not patients did better with continued ibrutinib after that year if they were MRD negative or not. So they were randomized, as you can see highlighted in the red box, to a placebo or continued ibrutinib monotherapy. These patients were all MRD negative at the time of randomization. Those patients who are MRD positive were randomized to continued ibrutinib monotherapy or continued combined therapy, as you can see below in the box below that. And I'll show you the outcomes for each of those. This trial did enroll patients who had high-risk features, including 17p deletion mutated TP53. These are the MRD negative rates at the end of 12 cycles of combined therapy, 75% MRD negative in the blood, 72% in the bone marrow. This was a large multinational, international study, multi-center international study. So there were a number of different centers that were enrolling patients on this study, and it was nice for us to see confirmation of our response rate that we saw at MD Anderson in this large international study. This shows you that there were 86 patients who were confirmed undetectable MRD. 43 were randomized to placebo, 43 to ibrutinib. There were a few more patients with higher risk features among those who were assigned to ibrutinib therapy, as you can see highlighted in red. And then there were 63 patients who had persistent MRD and were randomized to either ibrutinib, 31 to ibrutinib monotherapy, and 32 to continued combined therapy. This is the primary endpoint. This is the outcomes, which is 1-year disease-free survival for the MRD negative patients. And you can see there's no difference in these curves in terms of 1-year disease-free survival if patients were randomized to ibrutinib, continued monotherapy versus placebo. And these data, for me, substantiate the concept of fixed duration treatment, achieving an undetectable MRD status, and an expectation for patients to have a longer-term progression-free survival without continued treatment. So that is the bottom line for me for this study. This shows you what happens to patients who were MRD positive and were assigned to continued combined therapy versus monotherapy. It's a little bit hard to see this. The hatched bars did not come through very well, but the bottom line here is that there are patients who do benefit from continued combined therapy. So for me, this raises the question of what is the optimal duration of treatment for patients who don't achieve an undetectable MRD status. Do we treat them for 2 years of combined therapy, etc.? And I do think there is value for continued treatment. This slide was just to remind me to tell you that we did not see any safety signals or unexpected toxicities with this combination, and patients tolerated it very well. Moving to the relapsed setting, the Murano trial was updated at ASH. This was a 5-year update for the Murano trial. This was for patients who were treated in the relapsed setting. They were randomized to venetoclax rituximab versus chemoimmunotherapy with bendamustine rituximab, all for previously treated patients. And this slide shows you on the left progression-free survival at 54 months median for venetoclax-based therapy in this setting. And overall survival is on the right, improved overall survival with venetoclax-based therapy in this trial and in this setting. Patients who achieve an undetectable MRD status at the end of treatment do better in terms of progression-free survival and overall survival than those patients who have persistent disease. Now, the Murano trial gave 2 years of venetoclax compared to CLL14, where patients received 1 year of venetoclax. And on this trial, the CD20 antibody was rituximab instead of obinutuzumab as in the CLL14 study. This summarizes, for patients who achieve an undetectable MRD status, what the kinetics of relapse for MRD are in the middle. So the median time to MRD relapse was about 20 months for those patients who are undetectable. And from time from MRD relapse to progression is shown on the right. And that's a median of about 2 years. You can see sort of a plateau effect on the middle curve, which is time to MRD relapse. So there are patients probably who are remaining undetectable and have long-term MRD relapse-free survival and therefore progression-free survival, even among patients who are treated in the relapsed setting. Well, okay, that didn't come out. But this slide was intended to show, let's see, this is long-term data outcomes for patients who receive ibrutinib monotherapy in the relapsed setting, and show that the median progression-free survival with ibrutinib monotherapy is about 44 months, which is consistent with what I just showed you with venetoclax-based therapy on the Murano trial. The high-risk patients, again, even in the relapse setting and in the frontline setting, remain to be those patients with 17p deletion, as you can see highlighted in the red curve for this ibrutinib monotherapy RESONATE trial. And with ibrutinib-based therapy, there was a prognostic model that showed the factors that were associated with shorter progression-free and overall survival for ibrutinib-based therapy, and those 4 factors are highlighted here. And I think we should pay more attention to some of the others that we haven't been more recently, which is beta-2M and LDH when patients are going on ibrutinib-based therapy, and these are just the curves that support that prognostic model. Pete Hillman presented data on the ibrutinib-venetoclax combination in the relapsed setting. We did a trial also that included relapsed CLL. They're seeing and reporting about a 40% MRD negative rate for this combination in the relapsed setting. And those are also summarized here in this plot. And they also are working on the optimal duration of treatment because they've modified their trial to allow an extended period of treatment until patients are MRD negative. And they also presented at ASH these data that indicate that patients who achieve an earlier response do better and are more likely to achieve a deeper response with this combination. And the progression-free survival curve on the left and overall survival curve on the right for this combination. So we're seeing very good, very deep remissions with the combination, including in the relapsed setting. I think some of those patients are cured. We just need longer follow-up, and we need to monitor for MRD relapse to support that statement. I think the last couple slides, I just want to touch on a new drug that appears to be very active that works in patients who have failed an irreversible BTK inhibitor and have developed resistance. This is LOXO-305. This is a very selective reversible BTK inhibitor that was shown to have activity in vitro and in animal models in cells that have acquired the cysteine 481 mutation associated with resistance to the irreversible inhibitors. This phase 1/2 experience showed very good tolerability with this drug. The maximum tolerated dose was 200 milligrams daily. And among patients, you can't see the responses on the right for this slide, but the response rate improves with continued treatment, and we did report at ASH responses among those patients who are refractory to ibrutinib or an irreversible BTK inhibitor, as well as venetoclax-based therapy. So this drug, I do anticipate seeing it approved, and it appears to be a very active drug, including in patients who are refractory to the irreversible inhibitors. This is duration of response for LOXO 305 and progression-free survival on the right. So this is my summary slide that sort of reviews the concepts and thoughts that I went through when I gave my talk. For first-line therapy, we have very active, effective drugs. With BTK inhibitor-based therapy, we're talking about long-term disease control with continuous treatment. With BCL2-based therapy, and particularly with our combinations, we're talking about fixed duration, deep remissions, time off treatment. My opinion is, and my observation is, that we're transitioning into an era of combined targeted therapies with this objective. 17p deletion and mutated TP53 remain high-risk features. Those are patients that we definitely need to work on to improve outcomes. But I do think in the targeted therapy era, for patients over 65, my opinion is that with the targeted therapies, their expected lifespan is not shortened by their diagnosis of CLL. And we're working on strategies to cure them with the first definition that I reviewed in my first slide. So with that, I'll thank you for your attention and be happy to take any questions.
Thank you so much for being on time. And now we're going to have the questions. So starting with the first one, a 40-year-old CLL17B deletion positive, no comorbidities. Which one you prefer to start with, ibrutinib or venetoclax?
Yeah. So this is a young patient with a high-risk feature. This patient has a high-risk feature even with the targeted therapy. This patient should absolutely not receive any chemotherapy or chemoimmunotherapy. This patient should receive targeted therapy, either BCL2 inhibitor or BTK inhibitor. If we're talking about standard of care and not on a clinical trial, my preference is for a BTK inhibitor because as I mentioned, I don't like the concept of fixed duration treatment for 17p deletion. I like to put them on a treatment and maintain them on treatment, sort of protected with treatment, because I think in the near future, we will have effective treatments for these patients. We're still working on them. And so I want something to treat the patient and long-term manage the patient until we have something better for them. Perhaps it's going to be CAR T or some other agents. But we do know the BTK inhibitors work for this patient and the BCL2 inhibitor worked for this patient. For this patient at MD Anderson, my preference would be to put them on a clinical trial with combined targeted therapy, because I do think the combined targeted therapy may get them in a deep enough remission where they can get off treatment, but we just need more data to substantiate that statement.
Okay, thank you so much. The next question is for Dr. George. A 40-year-old male patient with CML started on frontline dasatinib, no other comorbidities. BCR-ABL at 6 months was 12% mutation analysis negative. And the question, do we prefer to switch to another TKI, and which one? The second thing is, or to continue on dasatinib till 12 months and assess the cytogenetic evaluation.
Well, this is an interesting patient because there is a borderline response, 12%. I am assuming that this is on the international scale, so I'm gonna take that as an assumption. I would definitely do a cytogenetic analysis at the 6 months as well to see what that represents. Because if this patient has at least a major cytogenetic response, then I will feel more comfortable even continuing therapy. In general, at that level, I tend to be more patient, and I know many of my colleagues in the CML field tend to recommend to jump therapy even at 3 months with more than 10%. But my experience has been that these patients can still continue to improve over time. So, first, again, do cytogenetic analysis, or at the very least FISH, but I would prefer a cytogenetic analysis. If I'm going to switch, I'm not going to switch to a second-generation TKI. They are the same. So there's very little chance that you're going to get anything better. you could get an improvement in the response, but it is possibly the same that you would have achieved with dasatinib. There was a randomized study of dasatinib versus nilotinib frontline from Japan at ASH, and it showed those curves are completely overlapping. So they're the same. So if I'm going to switch, I'm going to switch to ponatinib. But again, my first reaction would be check the cytogenetics at 6 months, continue the dasatinib, make sure that you're optimizing therapy, minimize interruptions, etc., and check again at the 12-month mark.
Okay, thank you. So what's the best timing to use combination with the start of therapy, or in case of deep response was not obtained down the road? I'm talking about the CML cases regarding the combination therapy.
I think combination therapy frontline is very difficult to justify. None of the studies have shown any real benefit. I think that the potential role of combination therapy is more likely to be later on. As you mentioned, those patients that have a good response but not the deep molecular response, potentially add an agent. What agent, we don't know. The studies, I showed something on ruxolitinib, and there's still ongoing studies, but our experience was not good. The combination of 2 TKIs with asciminib sounds very intriguing. I kind of like that, but there are 2 TKIs, kind of similar mechanism of action. Venetoclax is intriguing. There's different options, so we don't know which one to use. But I think if we're going to use combination therapy, it'll be more in that context, in the later responders but not deep molecular responders.
Okay, and how about the combination of PD-1 inhibitors and CML patients?
PD-1?
Yeah, nivolumab. There are like trials. Still, it's a phase 1 trial.
Yeah, there's been some attempts at that. The first trial was done only in blast phase and didn't show much, but that's a difficult test. I think that there is the potential. CML is a very immune-prone disease. It could be that you, especially using it, I would again use it only to deepen the molecular response later on. And I think it is possible that you need relatively low doses, few doses, so it wouldn't be as onerous on a patient. Because those patients are taking pills and they don't want to be taking intravenous medications. They don't want to get sick. You don't want to risk having, immune problems, etc. So I think there's the potential for benefit there, but we need to see the data. Of course, as you say, there are clinical trials ongoing. They'll have to be very, very convincing. Can they be? I think so. I think there is a potential, but we don't have data yet.
Right. Thank you so much. So then the other 2 questions to Dr. Philip. Were those excellent results with the newer combination obtained in the real life setting outside the clinical trials? What do you think?
Well, in fact, we have very, very few data on real life assessment of quadruplet combination, for example, with VTD Dara or VRD daratumumab or carfilzomib Lendex KRD plus a CD38 antibody. No data are available. We have some data on VTD in the real life. Triplet combinations were published in the real life, showing almost similar results compared with those achieved in routine. In clinical trials, but with quadruplet combination, not at all. And this is something that should be definitely evaluated in the future.
Right. The last questions. Where, like any of the trials, assess the quality of life, and in particular with the use of the multiple drugs for prolonged time and overlapping toxicity in multiple myeloma cases, especially those patients, they're like a middle age or above 60.
Yes, in fact, for example, with the Cassiope study, we looked at VTD versus VTD daratumumab plus stem cell transplantation, and we looked at quality of life, and the data were published in the Lancet Hematology very recently, and we are showing that the quality of life is totally maintained. The addition of a CD38 antibody that is very safe, in fact, is not adding any significant toxicity. So I guess that this was also shown with other regimens. You know that, for example, with the DRD combination, Lendex versus Lendex plus daratumumab in elderly patients at ASH, there was also some data on quality of life showing that the triplet combination Lendex daratumumab is not associated with any toxicity or significant toxicity added on top of Lendex. And the quality of life was even improved, in fact, because you are controlling the disease much faster, in fact. So yes, we do have quality of life assessment. That's mandatory, I would say, for all recent phase 3 trials.
Dr. Amal, you are muted. Dr. Amal.
Oh, okay, sorry. The last question is, if we're going to mention or talk about the cost effectiveness and availability of those medication, have you thought about it? I mean, not all countries can get those medication, or some of the patients, they do not have insurance to cover the cost of that treatment. Any thought or idea how to overcome this?
Well, in fact, that's true that the cost now of new quadruplet combination with the addition of daratumumab, that is very expensive, lenalidomide, that is also quite expensive. We are reaching costs that are very, very, very high, in fact. And drug access and drug availability is really an issue, you know. Even in the US, I know that my colleagues are now raising some concern about the cost of treatment. So definitely, we need to find other options. And one example, we are looking in the relapse setting at pomalidomide, dexamethasone, and daratumumab. And if you don't have access to Dara, you can easily add on top of Pomdex cyclophosphamide. That is also very effective and probably act in synergy with an IMiD. And you can really have good progression-free survival data with Pomcyclodex as compared with other combinations that are much more expensive. So definitely, for example, in the recent paper published a few days ago, the International Myeloma Working Group recommendation for treatment at the time of the relapse, we are proposing alternative combinations, other combinations that are quite effective when we don't have access to carfilzomib, to pomalidomide, or to CD38 antibody. But definitely, that's a very important issue.
Right. There one more question: how to manage the resorbed bone after auto transplant, and when?
Sorry, I didn't hear the start of the question. Yeah.
Okay. How to manage a bone after transplant, and when?
Oh yeah.
After
well, we have some guidelines of the use of bisphosphonates, for example, in the setting of autologous stem cell transplantation. These guidelines are published. We have the ASCO guidelines. We also have the European Myeloma Network guidelines. And usually, you know, in the setting of frontline stem cell transplantation, we are recommending, for example, bisphosphonates monthly for a period of time of 2 years and not more than this, in fact. So this is one example of what we can do, monthly administration up to 2 years.
All right. Okay, so by that we conclude our session. I would like to thank all our eminent speakers. We really enjoy it, and like by now we have almost 4,000 attending the session. So thank you so much, and hope to see you soon in other conference or visiting us in Saudi Arabia. Thank you all. And we are moving now to, we have a break and opening the exhibition.
Thank you.
Pleasure.
Thank you very
Thank
much.
you. Bye-bye. Take care.
Hi, Bill. How are you?
Bye.
Good. Erhard. Jorge.
As Dr. Amel mentioned, there will be a break and we will rejoin in 15 minutes. Please utilize this time to visit the virtual exhibition hall, and you can do a tour and contact the representative.
Welcome back. Now I'm going to introduce my next, my colleague for the next session, Dr. John Apsolides. He is a consultant hematologist in the Department of Adult Hematology and Stem Cell Transplant at King Fahd Specialist Hospital in Dammam. Welcome, Dr. John. The floor is yours.
Thank you. I would like to thank the scientific committee for the honor to moderate this evening's session of an outstanding meeting. We have a panel of distinguished speakers that will address very interesting topics. The first part will include presentations by Dr. Francine Foss and Drs. Jane Armitage, followed by two satellite presentations chaired by Dr. Faraz Al-Farih. A question and answer session will be held after the first satellite presentation. I encourage the audience to submit their questions through the Ask Question button under their screen. So without any delay, I would like to introduce our first speaker, Dr. Francine Foss, who is Professor of Medicine in the section of Medical Oncology at the Yale Cancer Center. Dr. Foss is an international recognized clinician and clinical researcher with expertise in adult lymphomas and in allogeneic stem cell transplantation. Dr. Foss has pioneered several novel therapies for T-cell lymphomas and has led significant national clinical studies in the USA. The title of the presentation is, "What is the future of immunotherapies for T-cell lymphomas?" So Dr. Foss, thank you for being with us. The podium is yours.
Hello, I'm Dr. Francine Foss from the Yale Cancer Center in New Haven, Connecticut, and I'll be talking to you about the future of immunotherapy in T-cell lymphomas. As you know, there are a number of different subtypes of T-cell lymphoma. This is the WHO classification showing you that T-cell lymphomas are divided into leukemic diseases such as T-cell PLL and LGL and adult T-cell leukemia. The nodal diseases more common, including peripheral T-cell lymphoma, angioimmunoblastic, and the anaplastic large cell lymphomas. Then we have the extranodal group, which includes NK T-cell lymphoma, enteropathy, hepatosplenic T-cell lymphomas, and paniculitic. We also have breast implant associated T-cell lymphoma that's a new entity. And in the cutaneous group, we have diseases such as mycosis fungoides and the Sézary syndrome and the CD30 positive anaplastic large cell lymphomas, among others. PTCL generally has an inferior outcome compared to B-cell lymphomas. You can see the distribution of subtypes shown here. And again, the nodal PTCLs such as PTCL NOS, angioimmunoblastic, and anaplastic large cell are the most common subtypes. With the exception of ALK-positive anaplastic large cell lymphoma, outcomes are poor for all of the other subtypes, with a median survival of 2 to 3 years for many of these. So upfront therapy for T-cell lymphoma is generally a CHOP type regimen. You can see that there have been some variations on CHOP, such as combining it with pralatrexate or combining it with a gemcitabine-based regimen. And you can see the outcomes with median progression-free survivals here are poor, less than 1 year, compared to what we expect with B-cell lymphoma. In addition, with T-cell lymphoma, we like to attain a complete remission upfront and then take a patient to an autologous transplant. The data shown here are the data from the Nordic study, which is a prospective study where patients got a CHOAP regimen. And then if they had a complete remission, they went to an autologous stem cell transplant. Even under the best of circumstances, you can see that the median progression-free survival and overall survival is that about half of these patients are going to fail this therapy at 2 to 3 years. And again, this points out to the fact that even when we use optimal therapy up front and get a complete remission, there's an unmet medical need for this disease. So we need to start thinking about novel therapies and novel ways of approaching these patients. Thus the need to look at immunotherapy as a possibility. The FDA-approved agents in the United States are pralatrexate, which is a folate antagonist, 2 HDAC inhibitors, romidepsin and belinostat, and then chitamide is approved in China, and then brentuximab vedotin, which is a CD30 targeted toxin. You can see the overall response rates are not exceptional, with the exception of brentuximab, and progression-free survival is short for these new agents. So the groundbreaking study in the last year or two was ECHELON-2, which combined brentuximab vedotin targeting CD30 with CHOP in patients with untreated CD30 positive PTCL. So for the purposes of this study, patients who had immunohistochemical expression in greater than 10% of their cells were eligible, and all histologic subtypes were eligible. The endpoint was progression-free survival, and then overall survival as a secondary endpoint. This was a randomized study with brentuximab combined with adriamycin, Cytoxan, and prednisone versus CHOP. And the outcome for this study was a little bit surprising in that there was clearly an improvement in progression-free survival for the brentuximab arm at 57 versus 44% at 3 years. You can see the p-value is 0.11. But also, interestingly, there was a survival benefit as well with a p-value of 0.2 for the brentuximab plus CHP arm. Now, if you look at the different stratification factors, you can see that all patients benefited, with the exception of angioimmunoblastic, which showed a slight preference for the CHOP versus the brentuximab. And again, the numbers are very small here, so it's difficult to conclude anything. Clearly, the patients with anaplastic large cell lymphoma with a high expression of CD30 did exceptionally well in this study. So what can we conclude from this data? Clearly, there's a benefit in overall survival with the brentuximab arm. However, most of the patients, about 66% of them, were anaplastic large cell lymphoma. So the real question is, will this data hold for other subtypes? The study was not powered to look at those other subtypes. And what is the role of consolidation transplant? Now that we have excellent upfront data, at least in anaplastic large cell lymphoma, is there a subset of patients that should not go to autologous transplant? I think that still remains an open question. In addition, we don't have data on the CHOAP plus brentuximab regimen. Many of us are incorporating etoposide upfront, and the studies are now ongoing looking at the combination of etoposide regimen with brentuximab. So if we use brentuximab CHP, do we even need etoposide? Is that going to be just as good as CHOAP, for instance? So again, these are subjects of ongoing trials. Suffice it to say, I think that there's still a question with respect to the benefit of brentuximab upfront in the other subtypes, and what is the optimal frontline regimen for many of our patients. So another question has been, should we incorporate other drugs upfront? And I'm just showing you this slide because there's been a lot of work looking at epigenetic mutations across the different subtypes of aggressive T-cell lymphoma. And angioimmunoblastic T-cell lymphoma is a subtype that has many of these mutations, including TET2 and DNMT3 and IDH2, in addition to the RHO-A mutation that occurs in about 70% of AITL patients. So it would make sense that you could approach these patients with epigenetic therapy. And in fact, there has been a study looking at 5-azacitidine. Again, this is a small study with AITL patients, but showing very good overall response and response duration, with a response rate of 75% in a small cohort of patients. So this was exciting data, and a subsequent study combined azacitidine with romidepsin in PTCL. And this was a phase 1 study looking at not only T-cell, but other histologies as well. Within the T-cell lymphoma group, the overall response rate was 73%. And you can see the doses of azacitidine given days 1 through 14, and romidepsin given on day 8 and 15 on subsequent cycles. And so this actually is a combination that's being taken forward in a larger study. So then if we start talking about immunotherapies and how we would approach patients with aggressive T-cell lymphoma, we'll talk a little bit about antibody-based therapies, checkpoint therapies, and CAR T. So touching on antibody therapies, this is mogamulizumab, which is a humanized monoclonal antibody that targets CCR4. And this drug is approved in cutaneous T-cell lymphoma in the United States and for HTLV-associated ATLL in Japan. Again, this is a naked antibody that's not conjugated. And it turns out that CCR4 is expressed across a wide range of malignant T-cell lymphomas. And this data shows you patients with mycosis fungoides at different stages that express CCR4. And you can see that as the disease becomes more aggressive, from patch to plaque to tumor, you can see the expression of CCR4 increases. So there was a trial, a phase 1/2 trial looking at mogamulizumab in CTCL. The drug was given weekly for 4 weeks and then every other week. You can see that in this small trial with mycosis fungoides and Sézary syndrome, there were patients with complete responses. And you can see an example of a nodal response, as well as patients with circulating malignant cells that disappeared very quickly on this trial. And so based on these results, a large randomized trial called the Maverick trial randomized patients between mogamulizumab and oral vorinostat. And there was a crossover for patients if they progressed on the vorinostat arm. There were 372 patients randomized, and there was no requirement for CCR4 expression, although that data was obtained. And again, all patients were eligible for the study with progression-free survival as the endpoint. You can see on the right-hand side of the slide here that patients with circulating cells with Sézary syndrome did better than patients with MF. Overall response rate was 28%, but it was 37% in those patients with circulating cells. And you can see stage 4 patients also had a very good response rate of 36%. The duration of response median was 14 months. And you can see that it was higher in the Sézary patients. So in this clinical trial, the progression-free survival endpoint was met, favoring mogamulizumab, as you can see. And if you look at the waterfall plot, you can see that most of the patients who received mogamulizumab did have some reduction in their overall skin score, even if they didn't attain a documented partial or complete response. Again, the compartment response was different, with blood response being higher. And this is actually very similar to what we see with CAMPATH as well. With respect to adverse events, there were infusion reactions and some drug eruption, which was difficult to discern from the underlying disease, as you can imagine. And sometimes we had to give steroids to get over the drug eruption and then move on with the therapy. Another interesting antibody not yet FDA approved is IPH4102, which targets the KIR3DL2 receptor. It turns out that KIR3DL2 is expressed in mycosis fungoides and Sézary syndrome, as you can see on these immunohistochemistry slides. In addition, you can see on the bottom that the expression is higher in transformed or MF with large cell transformation and Sézary syndrome than it is in patients with patch plaque stage disease. And in an early trial with 44 patients with advanced CTCL, many of whom were Sézary patients and heavily pretreated, you can see that many of these patients had very good clinical responses. And based on this data now, the FDA has fast-tracked this drug for a larger study for approval in patients with CTCL. So that's going to be very exciting to see those results. I'll talk about checkpoint inhibitors now because that's obviously an area of great interest for us in other diseases, solid tumors, Hodgkin's, myeloma, etc. But it turns out that in PTCL, the data with checkpoint inhibitors is not yet where it is in other diseases. So in small studies with pembrolizumab and nivolumab, the overall response rates were not impressive at 33 and 17% in small numbers of patients with PTCL. However, the real winner for checkpoint inhibitors in T-cell lymphoma are the NK T-cell lymphomas. And this is data from our colleagues in Japan and the Far East, where they've extensively used checkpoint inhibitors in NK T-cell lymphoma and have seen some very impressive responses. In addition to seeing these clinical responses, there's been clearing of the infiltrate on serial biopsies. In addition, there's, as you can see, there's improvement and disappearance of the EBR positive cells. So this is a setting where you clearly could think about checkpoint inhibitors. However, in another disease, adult T-cell leukemia, checkpoint inhibitors have been associated with progression of tumor. And this is there have been a couple of articles published in the New England Journal and other journals as well, looking at small numbers of patients with ATL that receive checkpoint inhibitors. It turns out that PD-1 is a tumor suppressor gene in patients with HTLV-1 and perhaps other types of T-cell lymphoma as well. And so when you use a checkpoint inhibitor, an antibody that blocks PD-1, then you remove the suppressive effect of PD-1 and you can have acceleration of the disease. And so in the context of this disease anyway, checkpoint inhibitors should be used with caution unless you're in a clinical trial setting. Another disease where checkpoint inhibitors have been shown to be useful are cutaneous T-cell lymphoma patients. It turns out that both PD-1 and PD-L1 can be expressed on patients with mycosis fungoides and the Sézary syndrome. And more interestingly, PD-L1 can actually be translocated as shown on the right-hand side. We've seen a couple of cases where this has been described. And so there was a clinical trial that was done by the CITN, the Immune Tolerance Network in the United States, looking at CTCL patients with pembrolizumab. This trial was recently published. And then you can see that the overall global response rate was 38%, with many of the patients having a complete or partial response. However, there were patients who had progressive disease, similar to what I showed you with ATLL. If you look at the progressive disease patients that I outlined in red here, 4 were Sézary and 2 were MF. Many of them were advanced stage disease. Many of them had multiple systemic therapies. In addition, we saw patients who had skin flare, and these patients were predominantly patients with Sézary syndrome. And the onset of skin flare did not correlate with response or progression, but skin flare was associated with the level of PD-1 expression in these patients. And also the cytokine IL-7 appeared to correlate with flare. Patients with higher IL-7 had a higher chance of skin flare. Another thing that we've seen again is aggressive progression of underlying disease. And this is one of my patients that really made me think twice about the use of checkpoint inhibitors off of a clinical trial. So this is a patient with CD8 positive aggressive T-cell lymphoma who received pembrolizumab, and initially on after the onset of this therapy, he actually had a flare. So he had perivascular infiltrate with mixed lymphocytes, but without evidence of his tumor cells, and that's shown on the top panel. However, 3 weeks later, he actually had worsening and exfoliation of his skin. And you can see that the new biopsies actually showed progression of his CD8 positive cytotoxic T-cell lymphoma with very aggressive skin manifestations. And so the point of this slide is that you can see inflammatory infiltrate and a skin reaction with pembro, but you can also see acceleration of the underlying disease. So again, I think use of checkpoint inhibitors really needs to be in the context of a clinical trial. I'm talking now just briefly about some microenvironment modulating therapies and how they might be implicated in T-cell lymphoma. So tipifarnib is actually a farnesyl transferase inhibitor that's been around for a long time, but it was found recently that it actually can target CXCL12, which is expressed in the microenvironment of many types of tumors, including aggressive T-cell lymphoma. And it turns out that in PTCL, the expression of CXCL12 in the microenvironment is associated with an adverse prognosis. And this is found in 50% of AITL and 35% of PTCL patients. And so tipifarnib actually downregulates CXCL12 expression in the microenvironment. And so there was a phase 2 study looking at tipifarnib in aggressive T-cell lymphoma with a response rate of about 40+%. That has not been published yet. And that study recently concluded. And this is one of my patients with PTCL with very aggressive stage 4 disease who failed CHOP therapy and went on to this clinical trial. He had multiple skin nodules, as you can see on the left. And after 2 cycles of tipifarnib, he had a complete clinical response. So this was very, very impressive. And I've seen this many times now, particularly in my patients with AITL. So I think this is going to emerge as a very effective therapy for patients with aggressive T-cell lymphoma that express a high level of CXCL12 in the microenvironment. Another thing about this drug is that it appears as though patients who have KIR3DL2 mutation have a higher chance of response. So those with the mutant KIR3DL2, as you can see, had a 75% response rate, whereas those with the wild type had a 25% response rate. So now we actually have biomarkers that will predict who's going to respond to this therapy. Another interesting drug is the myeloid checkpoint inhibitor CD47, which binds to SIRP alpha and provides a checkpoint against phagocytosis of cancer cells. This is an important pathway in patients with T-cell lymphoma. If you look on the right-hand side, you can see CD47 expression on different types of T-cell lymphoma, as well as T-cell lymphoma cell lines. And so these anti-CD47 antibodies now are in clinical trials in T-cell lymphoma and have shown efficacy. It turns out that the antibodies in an animal model system of T-cell lymphoma actually show activity to suppress the disease in various sites, such as the liver and the spleen, as shown here. And these animals had prolonged survival when they were treated with the anti-CD47. These slides are from Salvia Jain, who actually did these studies and presented this data. So now we're starting to think about CD47 as a therapy for these patients. And in addition, there's a concept to combine CD47 antagonists with checkpoint inhibitors as well. So I'll just briefly close with CAR-T. So CAR-T, of course, is of great interest in many different diseases. With respect to T-cell lymphoma, the antigens that could be targeted are varied, and there are various issues that could arise with CAR-T therapy. So the CD30 CARs are in clinical trials for CD30 positive T-cell lymphomas and have shown activity in early studies. In addition, there's a CD5 CAR, and with the CD5 and the CD3 targets for CAR T-cell, fratricide is a significant issue, as well as long-term T-cell aplasia. So the CAR that I'm interested in that we have in clinical trials is a CRISPR-edited CAR that targets CD70. So CD70 is an important molecule physiologically in that it's expressed on activated lymphocytes, and its role is to control naive and memory T-cell activation via CD27. And it turns out that there's an elevated expression of CD7 on many different types of diseases, including T-cell lymphomas. And it possibly plays an immunosuppressive role due to T-cell exhaustion, apoptosis, or Treg expansion. So this has proved to be a reasonable target and an interesting target in T-cell lymphoma. So via a multiplex editing, a CAR has been produced, which is an allogeneic CAR directed against CD70. So to prevent graft versus host type reaction with this CAR, the T-cell receptor expression has been disrupted using CRISPR-Cas targeted to the TRAC locus. In addition, the CD70 gene is inserted into the TRAC locus. And to enhance persistence of these cells, the MHC1 expression is eliminated by disrupting the beta-2 microglobulin gene. And so that's produced this allogeneic CAR that's capable of targeting CD70 and also having persistence and not being subject to fratricide. So this CAR is now in clinical trials, just starting clinical trials in aggressive T-cell lymphoma, already showing some very promising activity. And this just shows you this particular CAR in a HUT78 T-cell lymphoma Sézary model showing very significant activity in tumor reduction. This is the clinical trial that's ongoing with lymphodepletion for 3 days, and then a washout for 48 hours, and then the CAR is infused. And thus far, we have not seen any significant T-cell aplasia associated with this, but it's early on in the course of this study. This is an immunotherapy platform for PTCL that's the subject of a global PTCL consortium, where we're combining a demethylating agent, azacitidine, with romidepsin, and then we're segueing in checkpoint inhibitors, in this case, durvalumab, and we're trying to look at different combinations of these agents to try to develop doublets and then triplets that potentially could be moved into frontline therapy, so that frontline therapy for patients with T-cell lymphoma would be fundamentally immunotherapy rather than chemotherapy. So then just in closing, I think there's a bright future for immunotherapy in T-cell lymphoma. We've seen novel antibody targets, and we're not yet seeing, but there are bispecific antibodies that are under construction that will be in clinical trials soon, as well as other antibody conjugates other than brentuximab vedotin that are now being developed. So I think those will be exciting. In addition, we've seen data for checkpoint inhibitors. We're now looking at combinations with other microenvironment modifying agents. And in particular, we are looking at combinations with mogamulizumab. There are various CAR Ts that are being developed, and I think CAR T therapy potentially in combination with other strategies would be very interesting. And again, our goal with all of this is to try to move immunotherapy further to the front line as a potential way of curing more patients. So with that, I'd like to close, and I'd like to thank you very much for asking me to speak at the forum, and I'll entertain any discussion questions. I just want to point out that there is an International T-cell lymphoma forum that we sponsor every year. This year, it's going to be a virtual event, and I would like to invite anybody in the audience interested in T-cell lymphoma to participate and/or to submit an abstract. Thank you very much for your attention.
Next outstanding speaker, Dr. James Armitage, who is a Joe Shapiro Professor of Medicine at the University of Nebraska Medical Center. He has served in numerous administrative positions, just as past president of ASCO and the ABMTR, as well as in many national and international oncology committees. He has published more than 800 papers, written over 100 chapters, and is editor, co-editor of 33 books, many of which, I should say, occupy space on my bookshelves of my library. The title of the presentation is, Are Targeted and Immunotherapy Regimens Going to Replace Platinum-Based Regimens and Autologous Stem Cell Transplantation for Salvaging Classic Hodgkin's Lymphoma? Dr. Armitage, thank you for being with us. We look forward to your talk.
Hello, this is Jim Armitage. I am pleased to have the opportunity to speak at the annual Saudi Hematology Conference. And the topic that I have today, that I was given, is targeted and immunotherapy regimens. Are they going to replace platinum-based regimens and autologous transplantation for salvage therapy in classical Hodgkin lymphoma? Now, this is not a trivial topic, actually, and we're going to have to choose specific bits of information to deal with to get it completely addressed in the time we have. So first, I would like to go back and talk just a little bit about autologous transplantation. You remember that Hodgkin lymphoma was almost always a fatal disease until radiotherapy was developed, and then still very few patients were cured by radiotherapy. And it was in the 1970s that MOP, the first effective chemotherapy regimen, was introduced, and that really made a big change in the survival of patients with Hodgkin lymphoma. However, didn't cure everybody, and patients still relapsed. In the 1980s, our team at Nebraska and several other institutions around the world began to try a new idea to see if we could rescue some of those patients with Hodgkin lymphoma who failed upfront chemotherapy. And this concept involved the use of very high dose chemotherapy, usually a regimen called BEAM, which is carmustine, etoposide, cytarabine, and melphalan, all given intravenously in very high doses that would be expected to cause permanent bone marrow injury. But patients had hematopoietic stem cells stored beforehand and then received the chemotherapy, then got the hematopoietic stem cells reinfused. This reestablished marrow function, and it turned out that we were able to cure some patients with relapsed or refractory classical Hodgkin lymphoma. Interestingly, unlike the situation for most aggressive non-Hodgkin's lymphomas like diffuse large B-cell lymphoma, a few patients with chemotherapy-resistant classical Hodgkin lymphoma were able to be cured with this approach. By the end of the 1980s or the early 1990s, work done here and other places led to replacing bone marrow-derived hematopoietic stem cells for those obtained from the peripheral blood by apheresis. And this became a standard therapy to try to cure patients with Hodgkin lymphoma who were unable to be cured by other approaches. The concept that was being used is this. If you look at these three curves on this slide, or columns on this slide, and this is the level that once the dose intensity represented by the columns, once the dose intensity passes this, then patients will die frequently from marrow toxicity. Patients that would be in this column would die from other organ toxicity. In each case, this is supposed to represent the amount of chemotherapy that would have to be given to cure a patient. And the idea that was being tested was that between the level of dose intensity that kills patients because of marrow toxicity and the dose that would kill a patient because of other organ injury, there might be a window of opportunity. And if we could replace bone marrow function, then patients could be cured uniquely, cured in a way they otherwise couldn't be. So after there were reports of phase 2 studies, it was appropriate that a phase 3 study was carried out in the early 1990s in the United Kingdom by Dr. Lynch. And they took 40 patients and they were randomly allocated to an auto transplant using the BEAM regimen, or the same drugs, but given at lower doses that could be administered safely without an autologous transplant. And you can see they had 40 patients. Most of these had multiple chemotherapy regimens, and half of them had never achieved a complete remission. So these were very high-risk patients. And here is the result. This is event-free survival. And you can see that around 70% of these people achieved a complete remission. And patients who had the auto transplant had much more durable remissions than those who received the same drugs at standard doses, confirming the idea that this was uniquely able to rescue patients. Now, we've done things a lot better since then. We have better source of hematopoietic stem cells, we're better at supportive care, and we're better at choosing patients likely to benefit from the auto transplant. And this is a series published in the British Journal of Hematology recently from Memorial Sloan Kettering, looking at a fairly large number of patients who underwent auto transplant for relapsed or refractory classical Hodgkin lymphoma. I want you to note that on the left-hand curve, the amount of people, these are event-free survival, you can see that about half of these people had long-term disease-free survival. And the overall survival was roughly comparable, with a few people dying from other things. So it still works, it's a curative therapy. And what we're going to do today is to see if it's always necessary, particularly in light of the new treatments that are becoming available. Before I do that, I want to address another issue that sometimes is forgotten. And that is that there are a few circumstances where the patient doesn't need some new innovative therapy and they don't need an auto transplant. They can be cured more simply with relapsed or primarily refractory classical Hodgkin lymphoma. This isn't very many patients, but it happens sometimes. And I'm going to talk about two situations in which this should be considered. One is that rare patient who has a relatively localized recurrence or area of resistant disease. And this was an abstract from ASH just a few months ago, where a group of hospitals pulled their data and found 22 patients. These were patients 2/3 of the time, they relapsed from a remission, and 1/3 of the time never achieved a remission. There were 3 patients of those 22 who failed, in addition to chemotherapy, radiotherapy, but the recurrence here was out of field. The patients all had relatively localized disease. That is, either one spot or a few spots close together that could be reasonably treated with radiotherapy. And this is the outcome. You can see that relapsed or refractory patients did about the same. Note that this time is in years. And so these patients, about 2/3 of them were continuously free of disease for 5 years after this therapy. It's something that's important to remember. It's way easier to give involved field radiotherapy than it is to do a transplant or to do some of the new treatments we're about to discuss. And it would be unwise to forget that once in a while, not very often, but once in a while, you'll find a patient that can be cured this way. The other treatment was just reported from the German Hodgkin study group, and they took people with early stage Hodgkin lymphoma, favorable early stage, who got ABVD and then relapsed. And some of these patients they treated with Biacop, as you know, a very intensive standard chemotherapy regimen, and others had the more standard therapy and auto transplant. And what you can see here, and why this paper was published in JCO just recently, is that for these patients who had localized disease, good prognosis patients, but were chemotherapy resistant to ABVD, that is, they relapsed after ABVD, you can see that the auto transplant was not significantly different in either progression-free survival or overall survival from giving the patients Biacop. Now, to be honest, I'm not certain that Biacop might not be more difficult than an auto transplant these days and has at least as high a risk of second malignancies later. But for patients who either couldn't be a candidate for an auto transplant or wouldn't want to pursue it, You can remember that if the patient failed ABVD and they started out with good prognosis disease, then sometimes they can be cured with Biacop. All right, now we're going to talk about these new treatments. And first of all, I want you to stop and remember that all relapsed and refractory patients are not the same. The regimens that they receive, both the number of those and the quality of them, for example, what we just talked about, ABVD and Biacop are different, and the number of treatments they failed can be different. The age of the patient can affect outcome. The extent of the relapse or where they were refractory and whether or not there's bulky disease. Their comorbidities, if they have renal failure, coronary artery disease, chronic lung disease, and so on, diabetes, these can all impact outcome. And whether or not the patients had failed a previous auto transplant or whether they were treated in lieu of an auto transplant with these new regimens. Now, this data is not always available, but we have to take into account the fact that the data we're going to look at is imperfect and we can't know how these variables might affect the outcome with confidence. All right, now here's what I'm going to talk about. I'm going to divide the new treatments up into these categories. These aren't the only new things available, but they're the ones I think are most interesting for us today. One is antibody toxins, and the only one we're going to talk about is brentuximab vedotin. It's obviously by far the most widely used, but there are some new of these compounds available. And so it alone, there are different immune therapies, but we're going to talk just about PD-1 inhibitors and some data on nivolumab and some data on pembrolizumab, and we're going to talk about their use as a single agent. Then we're going to talk about combinations of these two or those and other things. Then we'll talk about T-cell directed therapies like CAR T-cell and bispecific antibodies. And some of these, and not all of them, will be in patients who failed auto transplant, but they can also be used after an auto transplant. We know that brentuximab vedotin today is frequently used as an adjuvant to transplant. Well, I'll show you a new approach to that. First of all, brentuximab vedotin as a single agent has a high response rate in relapsed refractory Hodgkin lymphoma that led it to be approved. About a third of the patients achieve a complete remission, so that's impressive. And the biggest toxicity is neuropathy or neutropenia. The neutropenia, under some circumstances, will require growth factor support. Now, note that this drug's been around for a while, and this is in months, and this curve covers about 5 years. And you can see that those patients who achieve a complete remission with brentuximab vedotin can do well, with a significant proportion of them, somewhere in the range of 2/3 of them, still in complete remission, approaching 5 years. So this is impressive. And in fact, a few patients do appear to be salvageable with relapsed refractory Hodgkin lymphoma with just brentuximab vedotin. Keep in mind, by the way, this is 2/3 of 1/3. So we're down to around 20% of patients, but still, that's impressive. Then what about single agent PD-1 inhibitors? First of all, nivolumab. And this is a recent paper of 243 patients, multi-institutional study. Of these patients, about a quarter had never received brentuximab vedotin. And you can see with this waterfall plot that the overwhelming majority of the patients had a response. More than 2/3 of them had at least a partial response, and some had a complete remission. A few of those are people who had failed both brentuximab vedotin and an auto transplant. What was the follow-up? Well, this is the responding patients, and you can see those patients who achieved a complete remission. Now, this is a minority of the patients, but those that did, at 1 year, about 85% were still in complete remission. It's difficult to look at this curve and be confident what the long-term outcome is going to be. Even the partial responders, about half of those were still responding at 1 year. And this is survival. And I want you to note, as is often true for patients treated with PD-1 inhibitors in a number of diseases, the survival was seemingly better than the response rate, with almost all the patients alive at around 2 years. So effective treatment. This is a similar data for pembrolizumab, but these are people who all failed brentuximab vedotin, and almost all of them an auto transplant. I want you to note that still, this is in weeks now, still at a year, about half the patients hadn't progressed. So it's not terribly different than the other data. And very high proportion continue to survive. Similar with less patients than nivolumab. All right. Well, if you had to choose between them, which is more effective, brentuximab vedotin or a PD-1 inhibitor, in this case, pembrolizumab, and we're choose this because this is the one that there has been a study to try to address this very question. This is data from a randomized trial, multi-institutional, taking patients who have failed an auto or in some cases an allo transplant for classical Hodgkin lymphoma. And you can see that at 1 year, a higher proportion of them continued without progression if they received pembrolizumab than if they received brentuximab vedotin. And this was a very significant difference. Once again, you see with brentuximab vedotin, you have this seemingly flattening of the curve with some patients going on for a long time. And in this case, similar outcome for pembrolizumab, where we have long enough follow-up to compare the two. But if you had to choose one or the other, and this is the only data you had available, it would seemingly be better to choose the pembrolizumab. I'd be cautious about what I just said, though, given the fact that there's longer follow-up for studies with brentuximab vedotin. Well, here is another situation, and that is using these drugs as consolidation therapy after autologous transplant for high-risk patients with classical Hodgkin lymphoma. I told you before, and I'm sure you all are aware of the fact that studies done primarily led from a group at Memorial Sloan Kettering showed that you take high-risk patients after an auto transplant and give them single-agent brentuximab vedotin, you improve the chances that they'll be long-term disease-free survivors after the auto transplant. It has toxicity, specifically neurotoxicity, but we know that it cures more patients. Well, these investigators reported 59 patients in this study from recent ASH. About a third were refractory initially. A little less than 2/3 were early relapses, and about 40% had extranodal sites of disease. These and a few other things made up the high risk factors, and 2/3 of these patients had multiple adverse risk factors. The goal was to give 8 cycles of this combination, and the median was 8. In over half the patients, they were able to accomplish this goal. There was 1 treatment-related death out of the 59 patients. And this is the progression-free survival in all the patients. Now, these were high-risk patients undergoing auto transplant. And if you're involved in this, you know that a 3-year progression-free survival in 90% after an auto transplant is very good. So this is really very encouraging. And this is the same data, but dividing the patients into who had only 1 high-risk factor and those who had multiple high-risk factors. And you can see that they all did very well. Of the patients who only had 1 of those risk factors, 100% of them continued free of disease according to the actuarial curve at 2.5 years, as opposed to 92% of those who had multiple risk factors. I think this is actually quite exciting data. And if the data holds up with longer follow-up, and perhaps there could be a randomized trial comparing brentuximab vedotin to the combination or each of the 3 parts. I think this has the chance to potentially change practice. Now, there are other ways we could do immune therapies. We could use targeted T cells. That is, do CAR T cell therapy. Now, it's been very hard to do in Hodgkin lymphoma because you had to develop the T cells for the right target. But they, in this study, also published in JCO just recently, they chose CAR T cells targeted at CD30. This is the first 41 patients treated. 10 of the patients had cytokine release syndrome, a relatively small number, and all grade 1. So this was a very well tolerated approach, and none of the patients had significant neurotoxicity. 62% of the patients responded, and half had a complete remission after the CAR T cell therapy. And this shows you the actuarial outcome. The overall survival is excellent, with 90% of the patients continue alive out to 3 years. But the progression-free survival was less encouraging, with a 1-year progression-free survival of a little better than a third of the patients. This is the first attempt at CAR T cell therapy. There's every reason to believe it'll get better, but at the moment, it doesn't look probably as encouraging as some of the other approaches we talked about. And finally, the other T cell therapy I want to mention are these bispecific T cell engaging antibodies. These are being used in increasing numbers of diseases. And instead of making CAR T cells outside the body, what you do is make this bispecific antibody that takes the T cell, attaches to it, and carries it to the target. This treatment, if it can be worked out, and if there is no new unexpected toxicity, this has the opportunity to potentially put CAR T cell therapy out of business because it would be cheaper, it's available to everybody. It's an interesting approach. And the data in some aggressive B-cell lymphomas is quite exciting. This is the first report I know of in Hodgkin lymphoma, and you can see that the results were less spectacular, where by 6 months, 3/4 of the patients had progressed, although there were a couple of long survivors. So once again, there's lots of questions here that need to be sorted out, and this is something to keep an eye on, but at the moment, not likely to be replacing auto transplants. So these are my conclusions. First, that it is certain that some patients with classical Hodgkin lymphoma who fail curative treatment can be cured as second-line treatment or even later. As I said, in this disease, some patients with much more advanced disease can still be cured with auto transplants. So we know that the possibility for cure exists. I would say my conclusion to the question that I was asked when I was asked to give this talk, my conclusion is that for most patients with chemotherapy-sensitive relapsed classical Hodgkin lymphoma, auto transplant remains the best choice. It has a longer follow-up. We know it can cure patients. A third thing would be a few patients with minimal disease that can be cured with radiotherapy or more intensive chemotherapy and don't need a transplant. Don't forget that. But finally, the most exciting information is this. I think targeted therapies are immunotherapies. First of all, it might be the best way to achieve minimal residual disease to allow a patient to get to an auto transplant in several circumstances. That is, cisplatin-containing regimens might be more dangerous and not more effective than it's going to turn out what we can accomplish with drugs like brentuximab vedotin or PD-1 blocking antibodies. Secondly, the data I showed you suggests that some patients can be long survivors with either brentuximab vedotin, probably nivolumab or pembrolizumab, and probably with the combination of the two. And if we could identify which patients might be cured with that approach, it might replace auto transplant for those patients as the best choice. And finally, the data I showed you about combinations of brentuximab vedotin and a PD-1 antibody, the study used pembrolizumab, suggests that the results are so good as a consolidating therapy after auto transplant that might replace brentuximab vedotin consolidation as standard therapy as an adjuvant treatment after autotransplant. I want to thank you for your attention. You can see that the companies with which I have a relationship, none of which would particularly apply here. And I want to thank you for listening. I'll be happy to answer questions or comments.
What do you think about the future for immunotherapy for B-cell? And this question by Abdullah.
Is that for me? Excuse me. I think, it's the same story with checkpoint inhibitors. I think we're still trying to figure out how to most effectively implement them. But I think the story with B-cell lymphoma is different because that's really where we're seeing success with CAR T. And I think and many of us are moving toward CAR T and also the bispecific antibodies that Jim just talked about are in clinical trials in B-cell lymphoma and also have been effective. So I'm thinking more in lines of cell-based therapies and bispecific antibodies rather than checkpoint inhibitors in diffuse large B-cell lymphoma.
Thank you very much, Dr. Is Dr. Armitage joining? I think they are waiting for him to join, but for the time being, I will look for any question for T-cell. And That was about the CLL question. No. This question about the large B-cell lymphoma, maybe we'll wait for that. And how many years almost does it take to cure someone with lymphoma in early stage? Maybe Dr. Voss can answer. How many years it will take to cure someone in lymphoma?
I think it depends. It depends on what type of lymphoma we're talking about. I'd be interested in seeing what Jim has to say about that as well. But you know, certainly with low-grade lymphoma, it's a long-term proposition, and we wonder whether we ever cure anybody. With aggressive T-cell lymphomas, for instance, people require upfront chemotherapy and autologous stem cell transplants. So that's at least a year of therapy. Now, because half of those patients are relapsing, we're giving maintenance therapy as well. So I think more in terms of a long-term approach with these patients. You know, so cure is definitely not as easy as it is with Hodgkin's.
Thank you, Dr. Voss. I can see that Dr. James with us. Thank you for joining, Dr. James. Dr. James, there was a question about the BDL1. I can see it here in the chat. So the question is, BDL1 expression markedly increase in diffuse large B cell lymphoma. Do you think, I cannot actually get the, what's he mean by the, maybe he's asking if the BDL1 expression is markedly increased in diffuse large B cell lymphoma.
That, well, diffuse large B cell lymphoma is not a disease, but a complicated group of illnesses. And to date, the only place that PD-L1 blockers have exciting data is mediastinal large B cell lymphoma, a particular subset, which, by the way, is much more like molecularly like Hodgkin lymphoma. So beyond that one example, there's no place that I've seen data or we have had any experience to suggest that it's going to be a very important therapy for most of the patients with diffuse large B cell lymphoma.
Dr. Voss, thank you, Dr. James. Dr. Voss or Dr. James, one of you, if you can answer the question about allogeneic stem cell transplant in T-cell lymphoma. Any take on that?
Sure. We have done extensive allogeneic transplantation in patients with both aggressive T-cell lymphoma and cutaneous T-cell lymphoma with success with graft versus tumor effect. Even in the haplo setting, we've been able to achieve that. The problem is that about 60% of people have a long-term remission, and we're still faced with late relapses, both early and late relapses. So I think we need to start thinking about what kinds of therapies we could administer after transplant. I've had very good luck with post-transplant relapses using brentuximab vedotin as well as donor lymphocytes. So I think certainly allogeneic transplant is a curative modality for many of these patients, but we need to monitor them carefully and we need to intervene early on if there's evidence of disease recurrence.
Francine, this is Jim. The one time that we would do an allo transplant as part of the initial therapy as an adjuvant is a hepatosplank T-cell lymphoma in a young patient. Do you agree with that? And would you use it in any other disease, any other subtype up front?
Absolutely. You know, we try to do allo in our gamma delta subtype T-cell lymphomas because the outcomes are so poor. So that is hepatosplenic, and some of these primary cutaneous aggressive cytotoxic T-cell lymphomas also can benefit if you can achieve a remission. But we're also thinking about it in the high risk, high IPI patients with aggressive PTCL, for instance, where we don't think that there's a chance they're going to stay in remission long with autologous transplant. Now that we have some CAR Ts coming in the T-cell lymphoma space, I think that's going to be an alternative, hopefully in the future, to allogeneic transplant. But certainly there are some very advanced stage patients with bad histologies that you might consider transplanting up front.
So excuse me, I'm back. Sorry for the technical issues. I'd like to welcome all the speakers to the podium here. So I would like to continue with the questions. Dr. Voss, you didn't mention anything about NK T-cell lymphomas. I mean, there have been impressive responses to immune checkpoint inhibitors. In your center, I mean, do you see any of these cases? We see a few of these here in Saudi Arabia, and they're challenging cases. So would you like to elaborate on that, please?
Yes, we actually see a fair number of these patients as well. We see a lot of early stage NK T-cell patients that we treat with asparaginase-based chemotherapy and involved field radiotherapy, and they tend to do very well and stay in remission. But we also see the more advanced stage 4 patients who need more aggressive strategies like SMILE or aggressive chemotherapy. I've definitely seen relapsed patients do well with checkpoint inhibitors. And my question to myself is that because the SMILE regimen is really very rigorous and very toxic, whether or not we should be using the checkpoint inhibitors as part of the upfront strategy. I think that would be a study to pursue in the future. But we don't see enough of those stage 4 patients like our colleagues in the Far East to be able to do those kinds of studies. But I really think that's the direction we should be going in.
Thank you. Dr. Armitage, you mentioned, you elaborated on the Keynote 214 study, which showed that there's an advantage in progression-free survival for patients who are treated with pembrolizumab as compared to brentuximab vedotin. But certain questions have been raised from this study. First of all, we know that patients who were on brentuximab vedotin could not complete 34 or 36 cycles of brentuximab vedotin in this study. It was impossible. The other thing is we know that patients with BV monotherapy following relapse after auto can be cured, even if this is a small number. But we don't have any data on the ability of these immune checkpoint inhibitors as monotherapy to cure patients with relapsed refractory Hodgkin's disease. Do you agree with that?
Yes, the study you mentioned is controversial. The data is the data, but there are a number of reasons to be cautious about, and I tried to say that when I spoke, that if that was all there was and it turns out to be true, then the PD-1 inhibitor would be better, but we'll learn more as time passes. And I agree with you that it's not clear that, right now at least, that a single agent PD-1 blocking antibodies are going to cure any significant number of patients with relapsed refractory Hodgkin lymphoma, although the responses are very good. And there are some patients who do well for a very long time. I have, in fact, the very first person I treated that way years ago is still well. So it's possible to have a long survival, but that's certainly not what happens to most patients.
So another question for Dr. Voss. So we've seen promising results with immune checkpoint inhibitors in mycosis fungoides and Sézary syndrome. You elaborated on a study that was published in the JCO. And are you running any studies comparing, looking at combinations of these immune checkpoint inhibitors with other novel agents, such as brentuximab vedotin or CCR4 antibodies or mogamulizumab?
So, excuse me, so there are studies now combining checkpoint inhibitors, and a lot of that focus is on combining them with HDAC inhibitors and demethylating agents and agents like pralatrexate. So I think there's certainly a lot of possibilities. I would like to see some evidence-based studies. So I would like to see some evidence of in vitro synergy for some of those combinations, because as you know, there aren't that many aggressive T-cell lymphoma patients or cutaneous T-cell patients out there. So I think we have to think carefully about what studies we undertake. But there's other checkpoint inhibitors that are now coming into the clinic. There's a TIGIT antibody that's about to enter clinical trials. I think that will be interesting. So I think we'll be starting to rationally be able to layer on these therapies. I'm interested in looking at the microenvironment as well, and perhaps combining other checkpoint inhibitors with agents that might modulate populations of cells. Like, you know, there's the combination of mogamulizumab and checkpoint inhibitors that's being looked at. So I think we need to think further and also look at rational combinations of these.
Okay, thank you very much for our outstanding speakers. I'm sorry, but our time is up. We have to go on with the next session. Thank you very much for attending. I will look forward to seeing you at some point live as this pandemic slowly resides. Thank you very much.
Thank you.
So I would like to, it's my honor now and pleasure to present the chair of the satellite presentation that's following. Dr. Firas Al-Fareeh is a consultant in hematology, stem cell transplantation and cellular therapy and director of the Unrelated Donor Registry Program at King Faisal Hospital and Research Center in Riyadh. He is the president of the Saudi Society for Blood Disorders. Dear Dr. Al-Fareeh, the microphone is yours. Thank you.
Thank you, Prof. John. Thank you to Dr. James and Dr. Francine for the elegant talks. So it's my great honor to introduce Dr. Carol Moreno. Dr. Carol Moreno, she's a hematologist from Barcelona, Spain. She has a deep interest in chronic lymphocytic leukemia. She is a board member of European Research Initiative for CLL. She has been the leading author for many publications. Dr. Moreno, she will be talking about redefining CLL standard of care in 2021, which is Janssen Satellite talk. I would like to welcome the almost 4,000 attendees who are still with us. So Dr. Carol, please accept our apology for the delay, and the floor is yours.
Thank you very much. So hello to everyone, and first of all I would like to thank the organizers for inviting me to give this lecture at the annual Saudi Hematology Congress meeting. So thank you, and I will try to give you an overview of the therapeutic strategies that we have available for patients with CLL in 2021. These are my disclosures. And to start with, I would like to show you that this diagram in which you can see that there are several factors that need to take into consideration when advising CLL therapy. And these factors are host-related factors, disease-related factors, safety associated with the different therapeutic approaches, and also in the relapsed refractory setting, the prior therapies. Among them, the most important factors that need to be considered when deciding therapy in an individual patient with CLL are age and comorbidities, also the presence of high-risk cytogenetics, namely P53 aberrations, the IGHV mutational status, and of course, in terms of the safety, we need to take into consideration whether the patient has some prior cardiac disorders or impairment of renal function, which can be relevant even in the era of targeted therapies. And in the relapsed refractory setting, still wild type and number of prior lines of therapy, and particularly response to therapy and its duration is very relevant. Having said that, you know that all patients with CLL have very heterogeneous disease. And because of that, we need to have, apart from the clinical stages, some prognostic markers that allow us to predict the clinical evolution of the patients. And apart from the clinical stages, the two prognostic factors that are well consolidated in CLL, and that if you check at the PubMed and you look for prognostic scores, such as those performed by the German CLL study group, the CLL-IP, the Barcelona Breno, from David Ostier, Rossi in USA, you can see that in all these prognostic scores, there are two common factors, and these are the two: the IGHV mutational status and the presence of P53 aberrations. And this is because we know for many years now that patients with P53 aberrations have poorer outcome compared to those patients without these P53 aberrations. And looking at this data that was published many years ago, I would like just to highlight that the presence of TP53 aberrations may be reflected by the presence of the deletion of the 17p, but that there are a number of patients that can present mutations in the P53 gene,
So there is 23% of the patients, if we take a look only at the patients with P53 aberrations, that can have mutations in the P53 gene with no deletion of 17p. Because of that, it's very important to check, when we check in the test for patients, to look at the deletion of 17p, and if it is negative, to sequence the gene in order to detect whether the patient has a P53 mutation. And this is very, very important because we know now from many years ago that patients who have P53 aberrations, no matter if they have deletion or P53 mutation, they do the worse in terms of overall survival than others. But apart from that, it's very important that you take into consideration that if you perform the NGS for P53, you're able to detect lower small clones of P53, even below 10%. And I would like to show you this study from the European Research Initiative on CLL, which clearly show that no matter what is the size of the P53 clone, if you have a patient with P53 mutations, even in a lower range between less than 10%, you can see clearly that this matters and that these patients, no matter what is the size of the clone, do worse than those patients who have wild-type P53 gene. Apart from that, another prognostic marker that I mentioned, that I will go very briefly, is the IGHV mutational status. We learned this many years ago, more than 20 years ago. We know that there are two clinical forms of this disease, those patients who have mutated IGHV genes versus those who have unmutated. We know that according to the mutational status of the immunoglobulin genes, the biological behavior of the CLL cells is different, as you can see here in this slide. But what is more important is that the patients who have unmutated IGHV genes, these patients tend to accumulate more genetic lesions which confer poor prognosis, such as P53 aberrations and also Notch1 mutations, FT3B1 mutations, and these patients have higher predisposition to suffer clonal evolution. In the end, we're talking about a population who have poorer outcome in terms of overall survival, while those patients who have mutated IGHV genes are those patients who have a good prognosis and usually are associated with good prognostic cytogenetics, such as, for example, deletion of 13q. Because of that, so we need to perform this test not only at the time of diagnosis, but just before starting therapy, because apart from being prognostic markers, these markers also allow to predict the response to some specific regimens. So this is very, very, very important. We don't need to perform these prognostic markers at the diagnosis, but they are necessary to test before starting therapy. And why is that? Because these are response predictors that will allow us to design specific therapeutic strategies for these patients. Here we have a summary of the response predictors that have been published over the last few years in CLL. So here there are two important points, that the response predictors are treatment modality dependent, and that among all these prognostic response predictors that you can see in this slide, the only fully consolidated response predictors that we need to perform before starting therapy are these two. P53 aberrations, because they clearly are associated with failure to chemoimmunotherapy, and we know that even in the context of targeted therapies, these patients do worse than those without these P53 aberrations, and patients with mutated IGHV genes clearly have a shorter duration of the response to chemoimmunotherapy. Other response predictors have been published, and you can see that there are many papers with complex karyotype, deletion of 11q, the mutations of the BTK, Notch mutations. These can be additional response predictors that can allow us to design specific therapeutic strategies, but please note that the only fully consolidated response predictors are these two, which are highlighted in red. In the recent years, well, I would say in the last decade, almost the last decade, so we have had a great improvement in the CLL therapy. thanks to the introduction of targeted therapies, particularly the introduction of inhibitors of the B-cell receptor signaling pathway, and also the inhibitors of BCL2. And probably the main characteristic of these targeted therapies is that these drugs act via p53 independent. And this is very relevant because I have already mentioned that patients who have p53 abnormalities do not take any benefit from chemoimmunotherapy. And for these patients, we need to treat these patients with targeted therapies. But what is the best therapeutic option for these patients? So if we take a look at the different randomized trials comparing targeted therapies versus chemoimmunotherapy in the front line, so sorry, I don't know, but this has disappeared when uploaded into the system. I don't know whether you can see this column. Unfortunately, I cannot see it, and it was in my original slide. So anyway, so what you can see here is that all targeted therapies, BTK inhibitors, have been compared with chemoimmunotherapy in the frontline setting. Ibrutinib, the second generation of BTK inhibitors, such as acalabrutinib, also BCL2 inhibitors such as venetoclax have been all compared versus chemoimmunotherapy. And all these trials clearly show that targeted therapies are superior to chemoimmunotherapy in the frontline setting, particularly in terms of progression-free survival. And there is only one study which shows only a benefit in overall survival, which is the trial that was performed in the younger population. I will go later to this trial. So if we take a look at the treatment algorithm that we are using in São Paulo Hospital in 2021, and also if you take a look also at the NCCN guidelines updated in last February, also the ESMO guidelines already published, I would like now to focus on the fact that the patients who have active symptomatic disease according to IWCLA criteria are these patients who have criteria to start therapy. If we take a look at the treatment-naive patients, age, comorbidities, and physical status needs to be taken into account. And when we have patients who have p53 abnormalities, the therapeutic options will be targeted therapies. And as you can see here, in São Paulo Hospital, our first option is ibrutinib, which is already stated in most of the guidelines. And the second option will be a time-limited therapy with venetoclax or obinutuzumab, keeping idelalisib, which is an inhibitor of PI3 kinase, the isoform delta, for later lines because of the safety profile of this therapeutic approach. But let's have a look at how we can manage these patients with p53 aberrations. So here we have a kind of summary in which you can see what is the efficacy of the different inhibitors of B-cell receptor signaling pathway in p53 patients, with p53 alterations in patients with CLL. You can see here these are the results. Long-term follow-up in the relapsed refractory setting, in which you can see that the median progression-free survival was more than 3 years, 40 months in patients receiving ibrutinib in the relapsed refractory setting. If we take a look at the idelalisib rituximab, the median progression-free survival was considerably shorter, 18 months. And in terms of the second generation of BTK inhibitors, acalabrutinib, you can see here that the median has not been reached, although I must say that this trial have a very short follow-up, just only less than 3 years. And because of that, we cannot see the median progression-free survival in patients receiving acalabrutinib. If we take a look at the long-term follow-up data with ibrutinib, which is the only drug that can give us this kind of information, you can see here that in the phase 2 study performed at the NIH with a long-term follow-up, 5 years, looking only at patients with p53 aberrations, we can see what is the response of these p53 aberrant patients, in which you can see that the progression-free survival is quite good, is near 80% at 5 years, and the overall survival, most of the patients are alive after 5 years in the frontline setting. Obviously, in the relapsed refractory setting, patients do worse than in the frontline setting. But a very good results when we compare this, obviously, with chemoimmunotherapy. And unfortunately, we cannot compare these results with other time-limited therapies such as venetoclax or with a second generation of BTK inhibitors, because we still have shorter follow-up with all the other targeted therapies. Additionally, at ASH last year, it was presented a long-term efficacy of ibrutinib in the frontline setting in patients only with P53 aberrations, and it was performed a pool analysis from 4 different clinical trials, recruiting only patients in the frontline setting, in which you can see that is according to the data that we have seen from the NIH, at 4 years, near 80% of the patients are free of the disease in this very high-risk population, and that patients are alive, near 90% of the patients are alive at 4 years. So ibrutinib as single agent given continuously in the frontline setting in patients with P53 aberrations probably is the therapeutic choice, and this is one of the reasons why in our hospital this is the first option for these patients. If we take a look at the BCL2 inhibitors, venetoclax, you know that in the development, it was approved first as monotherapy, but now it has been approved in combination with anti-CD20 monoclonal antibodies. And if we take a look at the time-limited therapy with the combination of venetoclax or obinutuzumab in the frontline setting, we can observe with a relatively short follow-up, just only 3 years, we can observe how patients who have P53 aberrations, when stopping the combination with venetoclax and obinutuzumab, we can observe how these patients are likely to have to progress. So because of that, time-limited therapy is now being debated in the scientific community, whether just time-limited therapy for a year will be enough for this high-risk population. Additionally, if we take a look at the efficacy of BCL2 inhibitors in patients with P53 aberrations, we can observe that in terms of the eradicating minimal residual disease, the patients who have high genomic complexity, which are the patients who have P53 aberrations, half of them still have high levels of MRD after 2 years of venetoclax rituximab, which probably is giving us the information that time-limited therapy for these patients, although it's desirable, is still, so we don't have what is the optimal time-limited therapy for this population. Let's have a look at the management of elderly patients with comorbidities or those with comorbidities. And if we take a look at the first trial that was performed many years ago, this is the final analysis of this trial published almost 2 years ago, the leukemia, which showed that ibrutinib was superior to chlorambucil in the frontline setting in patients older than 65, and there was a benefit not only in terms of progression-free survival, but also in terms of overall survival. And this benefit was observed independent of the high-risk cytogenetics, such as deletion of 11q or the presence of mutated IGHV genes. This trial led to the approval of ibrutinib in the frontline setting, but of course, this was a comparison between ibrutinib versus chlorambucil and not chemoimmunotherapy. Because of that, many trials after that were published. Already, this has been already published, and we have some data in terms of randomized trials comparing ibrutinib-based therapy versus chemoimmunotherapy, mainly chlorambucil, obinutuzumab, or bendamustine rituximab, in elderly population or those with comorbidities. We have the Illuminate trial and the Alliance trial. I will show you very briefly the results, but this is just to remind you that ibrutinib in combination with obinutuzumab in the frontline setting improved progression-free survival compared to chlorambucil obinutuzumab in this elderly population, including patients with high risk. As you can see here, the benefit in patients with high risk was clearly superior. Progression-free survival at 3 years, 72% versus 12% in the patients receiving chlorambucil obinutuzumab. Additionally, when we take a look at the different prognostic markers that I mentioned at the beginning of my talk, you can see that there is a clear benefit in patients, whether they are unmutated or mutated, whether they have mutated or mutated IGHV genes compared to chemoimmunotherapy. Another trial that compared also ibrutinib-based therapy versus chemoimmunotherapy versus bendamustine rituximab in elderly population was the Alliance trial. The 3 years follow-up was published in New England Journal of Medicine in 2018. And you can see here that there is a clear benefit in terms of progression-free survival of patients receiving ibrutinib, either alone or in combination with rituximab versus bendamustine rituximab. And this benefit was observed in all different prognostic subgroups, including complex karyotype and mutated high-risk cytogenetics. And of course, in terms of the ICHV mutational status, we couldn't see any differences in terms of progression-free survival at 2 years between those who received bendamustine rituximab versus those receiving ibrutinib. Although with longer follow-up, we are seeing how these curves have started to separate it in between, and probably we will see a benefit with longer follow-up of this trial, even in patients with mutated ICHV genes. Other drugs, targeted therapies already available in this elderly population is acalabrutinib. This is a second generation of a BTK inhibitor, which is more selective than ibrutinib to BTK. And this is a trial that was performed in the frontline setting in elderly population with or without obinutuzumab versus chlorambucil obinutuzumab. You can see that the median follow-up is short, it's less than 3 years. This study was already published at Lancet and led to the approval of acalabrutinib in the frontline setting with or without obinutuzumab. You can see clearly significant benefit in terms of progression-free survival in those receiving acalabrutinib versus those receiving chlorambucil obinutuzumab. Of course, this trial was not designed to look at differences between those receiving acalabrutinib alone versus those receiving acalabrutinib with obinutuzumab. And because of that, the approval of this drug has been with or without obinutuzumab in this elderly population. The time-limited therapy available for the elderly population is the venetoclax in combination with obinutuzumab given for 6 cycles, and then venetoclax for a year. And you can see, well, this trial was already published and led to the significant benefit in terms of progression-free survival in patients receiving venetoclax obinutuzumab. But probably the most important consideration with this time-limited therapy is whether this is an optimal therapeutic approach for patients with high risk. And as you can see here in this sub-analysis, according to the ICHV mutational status and also according to the P53 aberrations, what is quite clear is that only with less than 4 years of follow-up with this trial, we can see how patients who have mutated ICHV genes or those who have P53 aberrations, when stopping therapy, we can see that there is a decline in the PFS curve. Probably, reflecting that these are the high-risk patients who are likely to progress when stopping this therapy. And this is something that we need to take into consideration when deciding therapy in the frontline setting. What about the safety profile of all these drugs? So I would like now to mention a few words between ibrutinib and acalabrutinib. I already mentioned acalabrutinib is a more selective BTK inhibitor, and as such, it was expected that the safety profile will be more favorable compared to ibrutinib. Here we have not the most frequent adverse events, but those the adverse events which are of clinical interest in terms of the BTK inhibitors. You can see fatigue, rash, neutropenia, hypertension, pneumonia, atrial fibrillation, bleeding, arthralgias and myalgias in patients receiving ibrutinib. And in acalabrutinib, we can see most of these adverse events again, but particularly is very, very frequent, the headache, which is characteristic from the acalabrutinib, and it doesn't appear in patients receiving ibrutinib, but we can also see some cardiovascular events, although it seems that the frequency, it can be lower. So I will discuss now this later on. If we take a look at the long-term follow-up in patients receiving ibrutinib and looking at the adverse events, we can observe in this elderly population with 5 years of follow-up that most of the adverse events are low-grade adverse events 1 or 2, and that most of them occur during the first 6 months, even during the first year. But after that, we can observe that most of these adverse events decline over time, except, I would say, hypertension. This is very important because, I mean, we are talking about a continuous therapy with ibrutinib as single agent, and because of that, it's very important to know that these adverse events decline over time. And this is what we are seeing, at least this is my clinical experience with the drug. If we take a look at the adverse events of clinical interest, so clinicians, we are concerned about, right? Major bleeding, atrial fibrillation, hypertension, and we can also observe that, again, most of these adverse events, particularly major bleeding, is very uncommon. It occurs around, it has been published around 4% of the patients, so this is more or less my experience in the clinic. Also, atrial fibrillation, although most of the atrial fibrillation are grade 1 and 2 and can be managed, but the atrial fibrillation can appear around between 6 and 8% in the clinical trials, a little bit high in the real-world setting. And hypertension, we can observe that there is a continuous frequency of patients who develop hypertension, although this is not really, is very easily to manage in the clinic, and no problems are, well, I haven't had any problem regarding hypertension generally, because they can be easily treated with drugs, and hypertension can be under control. I would like to mention that if we take a look at the trials, so in most of the trials, you cannot see that even in more than 50% of the patients in the ibrutinib trials, patients were receiving anticoagulants and also antiplatelet agents. So here I would like to mention that it's clear that the dual antiplatelet therapy is contraindicated in patients receiving ibrutinib, but we can treat patients with ibrutinib either with antiplatelet agents, such as aspirin, for example, and also anticoagulants, particularly direct anticoagulants, DOAC, direct oral anticoagulants, which are allowed and can be given at the same time with ibrutinib, and no major concerns can occur. If we take a look at them in terms of infections, I would like to highlight the fact that ibrutinib has shown somehow a partial restoration of the immune function, particularly the humoral immune function, and this is correlated with the decrease in the infection rate that we observed over time in patients receiving ibrutinib, particularly in the frontline setting. I would say that in the relapsed refractory setting, we obviously need to take into consideration prior lines of therapy, and maybe depending on the prior lines of therapy, if the patient received chemoimmunotherapy, to treat these patients with some prophylactic antibiotics. But in terms of the treatment-naive patients, so I can say that there is no major concerns about infection, and most of the infections decrease over time after a year, and they are associated with somehow a partial restoration of the immune function. This is well stated because we know that because of ibrutinib not only inhibits BTK, but also inhibits ITK, which is involved, the enzyme which is involved in the T helper differentiation. And because of that, we know that ibrutinib led to a T helper 1 skew repertoire, which can be responsible, have been associated somehow with the efficacy of the drug about restoring the immune system and also being able to control the tumor growth. This is one of the papers that was published many years ago by the group of John Baird. And after that, there is some data regarding how ibrutinib can restore immune cell populations. And this is a very busy slide, but I would like just to show you that there are a lot of the studies just showing that there is a partial restoration of not only on the numbers of T cells, the CD4 and CD8 T cells, but also in terms of the macrophages, monocytes, and obviously the function or the activation of the T cells seems to be restored, and that can help also to control the disease, not only through the BTK inhibition, but also the ITK inhibition may play a role of this. And this is one of an hypothesis that probably the restoration of the partial restoration of the immune system probably may lead to lower infections, a better outcome over time in patients in which we are not really eradicating the disease as we are seeing in patients receiving ibrutinib. Actually, this is just a brief summary just to show you that there is not only an impact on malignant B cells, but also there is an impact on the immune system. And because the immunosurveillance and the restoration of the immune B and T cell populations may have an effect, an indirect effect that has been clearly associated with particularly with ibrutinib. In terms of adverse events, I would like just to show you that there are some secondary, the next generation of BTK inhibitors, such as acalabrutinib, has been already approved. And this is the data that I showed you, the frontline setting, the only study that we have in the frontline setting. So, I mean, it seems that there is a more favorable safety profile in terms of atrial fibrillation, hypertension, and major bleeding when compared probably with ibrutinib, although still there is a discontinuation due to adverse events, which is not negligible. 11% and 9% of the patients discontinue the drug. And still, I would say that we still need to have real-world data with this drug and longer follow-up in order to have solid conclusions in terms of these adverse events. So probably we will see in the near future a randomized study which has been performed, ibrutinib versus acalabrutinib, that probably will give us some information in terms of the safety profile of the both drugs and whether one has a more favorable safety profile compared to the other in terms of cardiovascular adverse events. And because of that, if we take a look at the Sampao algorithm, and we have already discussed all these therapeutic strategies in elderly population or those with major comorbidities, BTK inhibitors is an option. We still don't have acalabrutinib approved in Spain, and ibrutinib is the first option for this elderly population, or venetoclax time-limited therapy can be an option, but particularly in patients who have mutated IGHV genes. So we can discuss that in the Q&A live session after that. How do we manage young CLL patients with no comorbidities? So there is only one study, which is the Coca-Cream trial, that compared ibrutinib given in combination with rituximab, ibrutinib at the standard doses, and rituximab given for 6 cycles, and then after that, ibrutinib was given as a continuous therapy versus FCR in the patients younger than 70 with a good performance status. Please be aware that there are no patients with P53 with deletion of C19P included, because the patients were randomized to chemoimmunotherapy. And this trial, with less than 3 years of follow-up, showed a clear benefit of not only progression-free survival, but importantly, a benefit in overall survival in patients receiving ibrutinib versus FCR. It's very important that the benefit of this drug was particularly observed in patients with unmutated IGHV genes, while in those patients with mutated, no significant differences were observed. And because of that, still chemoimmunotherapy can be considered an option in patients younger than 70 with mutated IGHV genes. In terms of safety profile, I would like just to add, we have seen the safety profile in the elderly population, but I would like just to mention that if we take a look at the safety profile in a younger population, in terms of the adverse events of clinical interest, we can observe that the frequencies are quite low as we compare the frequencies observed in elderly population.
Dr. Moreno, 1 minute, please.
Sorry? Sorry?
1 minute.
Yes, I'm finished.
Do you hear me?
Yes.
Thank
so
you.
in elderly population, according to the IGHV mutational status, so we need to consider in those mutated, still chemoimmunotherapy can be an option, and in those unmutated, the ibrutinib will be the first therapeutic choice. Having said that, I would like just to summarize that the patient-related factors, disease-related factors, and prior therapies need to be taken into consideration to select the most appropriate therapy in CLL in 2021. That overall targeted therapies, BTK inhibitors, and venetoclax-based regimens have shown to be superior to chemoimmunotherapy in the treatment-naive and in the relapsed refractory setting, that the P53 aberrations are still negative outcome predictors for BTK inhibitors and venetoclax-based regimen, but the long-term follow-up data with ibrutinib as single agent led that ibrutinib will be the therapeutic choice for patients with P53 aberrations in the frontline setting. Combination of different small molecules with or without anti-CD20 monoclonal antibodies, such as, for example, the combination of ibrutinib and venetoclax, will probably replace single agents in the near future. T-cell therapy still is an option, but for highly selected cases refractory to targeted therapies, and treatment modalities should be chosen based on a risk-oriented treatment plan from the initial to second and subsequent slides of therapy, because still we need to determine what is the best sequential therapy for patients with CLL. And of course, trials and real-life data are needed in order to improve our knowledge about how to treat the patients with CLL in the future. And thank you very much. This is all.
Thank you, Prof. Moreno, for an elegant talk. Due to time constraint, I will take two questions. So the first question is, are we expecting fixed duration in near future for ibrutinib and CLL?
Yeah, yes, but probably this will be in combination with venetoclax. I mean, there are some trials, because of the sake of time, I couldn't show more information, but there are some trials which have already combined ibrutinib plus venetoclax, given for a time-limited therapy for a year or 2 years, which are showing, and we have seen some data attached, which are showing a very good results in terms of eradication of the disease. And probably we will be able to stop therapy. Time-limited therapy will be possible with ibrutinib, but always in combination with BCL2 inhibitors.
Okay. The second question I have is regarding the addition of anti-CD20. So why it's more prominent in acalabrutinib, not in ibrutinib?
Yeah, that's a very good question. So I mean, we haven't seen any benefit of the addition of anti-CD20 monoclonal antibody in patients receiving ibrutinib. This has been shown in several trials, and because of that, ibrutinib as single agent is the standard of care for patients. But in terms of acalabrutinib, it seems that this drug, because of the more selectivity to BTK, doesn't interfere the DTC that is part of the function of the anti-CD20 monoclonal antibodies. It's one of the pathways of the anti-CD20 monoclonal antibodies, and because of that, probably because there is no impairment of the ADCC, because of that, probably acalabrutinib has more benefit in terms of adding obinutuzumab, as we have seen in the trial already published by Sharman. But I would like to say, I mean, the main problem is that we have also ibrutinib in combination with obinutuzumab, which has been already approved by FDA and EMA because of the Illuminate trial. And what we are seeing with these anti-CD20 monoclonal antibodies is that we are able to increase the rate of undetectable minimal residual disease, but these trials were not designed to stop therapy at any time. So unfortunately, the addition of anti-CD20 monoclonal antibody, while it can be, it can improve the quality of the response, it has no impact in terms of stopping therapy in these patients. It's true that we are seeing that there is a superior progression-free survival in the ASCENT trial in patients receiving obinutuzumab, but the differences are not statistically significant, and the trial was not designed to see differences. But this is probably because of the ADCC impairment with ibrutinib, while we are not seeing this with acalabrutinib. Yeah, very important question.
Thank you so much. So by this, we will conclude this presentation. Thank you, Professor Caro Moreno, for your time and very nice presentation. We will move to the next. So the next, thank you. So the next talk is invasive fungal disease in hematology patient, New Frontier. This is a Gilead satellite talk. It will be given by Dr. Varun Mehra. Dr. Varun Mehra is a hematologist practicing in King's College, London, UK. He has an interest in infection and immunocompromise, as well as graft versus host disease. So, Dr. Varun, the floor is yours.
Thank you, Dr. Alfra. Thank you for inviting me over to speak on this topic today, and thank you to Gilead for inviting me to be a speaker on this forum. I'll share my screen. Let me know if there is any issues. Oops, it seems like.
So if you.
Go ahead.
Prof. Varun.
Yeah, is it all ready? Yeah.
Yes.
Okay, very good. Sorry, it seems like it's a bit out of proportion here, the slides. So no, thank you once again. So yes, I work at King's College Hospital. I'm a consultant hematologist with special interest in myeloid malignancies and stem cell transplantation, but my research interest is in invasive fungal disease in immunocompromised host. And I would like to talk to you about the new updates as well as challenges we face in terms of managing these invasive fungal disease in our group of patients in hematology. This is my disclaimer, sponsored by Gilead, so thank you for inviting me over. And these are my disclosures for my involvement with the industry partners in different roles. And this is where I work. Just a quick summary, that we one of the largest academic health centers in the UK and largest healthcare provider, and have a multiple number of sister hospitals attached as part of our King's Health Partners initiative, in which we have guys in St. Thomas's Hospital, ourselves, St. Maudsley Hospital, and King's College London University, all making the biggest academic health service center in the UK. And in our department, we're a large department with a large consultant pool with 56 adult inpatient beds, and we do around 280 transplants a year. We are the largest CAR-T center in Europe, doing at least 150 CAR-Ts in the last 3 years. The reason, obviously, I'm here is to try and just have a discussion around why fungus is becoming increasingly a challenge rather than something that we all are familiar with and able to treat. It's mainly because it's just increasingly being identified as a difficult infection to treat, and mainly because we're now having much more access to novel immunobiological therapies. We have increased number of patient cohorts who are now becoming eligible for these immunobiological therapies, which poses new risk for developing fungal disease. We also are running out of treatment options because they are becoming more and more resistant with time, especially with azole resistance becoming a bit more widespread. And that brings a huge challenge for how we will manage this so-called explosion of potential invasive fungal disease and opportunistic infections in our patients. Just to remind the people about how fungi is classified. So we have molds, yeast, dimorphic fungi, but within the hem-onc settings, we normally see Fusarium as an Aspergillus infection, as septate fungi, more commonly Aspergillus infection in our hemato-oncology patients, and less commonly mucor infections. We do see fair share of Candida infections, mainly in line infections, biofilm type infections, or post-surgical infections in ICU, for example. but Aspergillus infection is what I will be focusing on in the rest of my talk. And why, again, it is important, because clearly there are lots of fungal spores all around us in the environment. They all come onto our epithelial surfaces and sometimes can give you nail, skin infections, and may not necessarily make you ill with that. But when you're immunocompromised, and these spores then tend to get through the alveolar epithelial cells and then start germinating, making hyphae and breaking through the epithelial barriers, and also then disseminating through the endothelial barrier junctions, leading to dissemination phase. And that angioinvasion property of these fungal infections, especially Aspergillus, for example, here, can be quite lethal or lead to high morbidity and mortality to these patients. And any steps that are being done to try and identify the infection at an earlier phase of their infection in human host, it will be the key to try and reduce further mortality and morbidity of these patients. And there's a huge amount of work being done to try and reduce this to happen in the first place, or if possible, have an early diagnosis done for these invasive infections. And then again, as I mentioned, our risk paradigm is changing, as we have just heard from the previous speaker about ibrutinib, for example, and other novel biologics that we're increasingly using are having a havoc on our host immune system, altering our macrophage functions, T-cell immunosurveillance, and that leads to further risk of these opportunistic infections. And you could see in the ladder that we have here, the high risk has been traditionally the allogeneic transplant patients, AML, MDS, patients receiving induction chemotherapy, or patients with prolonged neutropenia, or receiving high-dose prolonged courses of steroids. But in the intermediate risk group, this is increasingly becoming more crowded, with ICU patients admitted with post-influenza, for example, becoming an increasingly a bigger risk. We talked about CLL, and ibrutinib and similar agents are proving more high risk for these patients. And then traditionally, this sort of diseases were low risk for infections, but now increasingly they are becoming intermediate risk category if you're treated with novel biologics. And then CAR-T checkpoint inhibitors therapies are increasingly now being added to this sort of risk kind of time points where you are worried about the alteration in the immune surveillance again, and the lymphodepletion part of immunosuppression that comes with CAR-T therapies, all leading up to higher risk of infections in these patients. Then going back onto a couple of those issues that I just mentioned, the respiratory viral illness, for example, patients who are admitted in intensive care units with severe illness, especially in the back of influenza A, for example, leads to quite significant higher incidence of fungal disease. For example, 19% patients who were admitted in ICU with influenza A developed fungal disease, compared to just 5% without influenza A. And that was much higher in the immunocompromised group of patients who were admitted in ICU with influenza A, reaching up to 32%, which is almost a third increase in the invasive fungal disease compared to the rest of the cohort they had in ICU. And that translated into higher 90-day mortality. About half of these patients who were admitted with influenza A actually died as a result of fungal disease, which went up to 70% in the immunocompromised group. And this was a very large study published in Lancet Respiratory a couple of years ago, which really drove in the risk problem with influenza A as a potential piggyback pathogen who can drive secondary fungal infections in these patients and lead to high mortality. And something that we are also now witnessing with COVID-19, for example, in the last 1 to 2 years, since this COVID-19 have wrecked everywhere in our hospitals, increasing ICU admissions, and then that leads to secondary fungal infections. Then we published this work in terms of diagnostic algorithm, because we did see that signal in these patients in ICU, and kind of were quite concerned about lack of diagnostics, and often they present quite late post-ICU admission and then contribute to significant mortality for these patients. It's something that needs to be considered in your care for these patients when you see them in ICU, for example. And then we published a diagnostic algorithm to try and help with that. The next question, really, we have to understand what other risk factors, patient-related factors, we may have to think about. And then we have been involved in a number of previous studies which has shown that baseline CT potentially is a predictive risk for developing fungal disease in these patients. And then when I mean baseline CT, it basically is CT scan done just before commencing any form of induction chemotherapy or conditioning treatment for the allogeneic stem cell transplant treatment. And then we looked up recently and just we presented that in our British Thoracic Society meeting just a couple of weeks ago, in which we showed a homogeneous population of 350 stem cell transplants were transplanted in our Center for Myeloid Malignancies. We could see there were high risk factors for developing abnormal baseline CT, which was noted in older patients with higher comorbidities, pre-existing lung disease, or if there is a pre-existing history of invasive fungal disease in these patients, and they were more likely to have baseline abnormal CTs. And what that translated into a poor poor IFD-free survival in patients who had more classical ERTC defined changes at baseline. So if you had those changes, your IFD-free survival was significantly worse compared to patients who had either a normal CT or non-ERTC defined ERTC changes. And this led to, again, if you did have fungal disease developed post-transplant, there was a clear survival disadvantage for these patients. So really it comes down to that, what is there at baseline that we could have tried to improve? And this was a prospective study in which we looked at regular biomarker screening. We did bronchoscopy tests in all these patients, and then we could find out that clearly a subgroup of patients who are at higher risk potentially have to have much more increased interventions in terms of diagnostic work, and then regular monitoring post-transplant to try and reduce the risk of them developing fungal disease. So clearly an area where more work needs to be done to try and identify how interventions may change the risk profile. And then, back to this novel biologics risk, in which we've just heard about talk on the ibrutinib and CLL, and I think it's important to highlight that the ibrutinib has been associated with increasing risk of opportunistic infections, mainly disseminated invasive fungal disease, even cryptococcosis type infection, CNS infections, and then primarily in the first 3 to 6 months of starting therapy. And that's been published case series wise, and there's some biological science work been also published since that suggests that there is alteration in the macrophage, alveolar macrophages, T cell dysfunction that leads to increased risk of these fungal disease in these particular patients. And then what about CAR-T? Because that is the next question. We're seeing more of these CAR-Ts in our center. We do a fair lot in the UK, and then our concern was that we're seeing increasing lymphodepletion related sort of viral infections, also fungal disease, but also there was long-term aplasia, which puts them at higher risk. These patients also get steroids, tocilizumab, for example, that puts them at a higher risk of developing these infections. And this early paper suggested there was definitely a signal of mold disease in these patients, and certainly in the UK NCCP data that we have certainly witnessed quite a few disseminated fungal disease presenting late post-CAR-T infusion, roughly around day 20, day 30 sort of mark, when they are aplastic and often have a poor outcome associated with these infections. So we have started doing more early prophylaxis for these patients because of the underlying risk factors that currently in our group of patients. And this is where just kind of to mention recently published sort of phases of CAR-T based infections, and you could see aspergillus infection do tend to occur not just early but a bit later in the CAR-T therapy recovery phase. Around day 56 is the maximum sort of risk period, but PCP still is a concern in the longer term follow-up. In addition to the respiratory viruses and the other viruses that we sometimes see, we recently published HHV6 related encephalitis in a late onset presentation, which was certainly a rare presentation, but these things do happen. So all of these infections put a big risk for something to worry about in these patients. And then we have now all these newer therapies that we're using for our patients in AML, ALLs, all the FLT3 inhibitors, BCL2 inhibitors, minor targets come back, inotuzumabs, and the CD20 antibodies. They all are now increasingly being available for our patients, and CAR-Ts including. But the challenge really is how using these drugs and then other antifungals that we currently want to give them has a risk in terms of their interactions with these agents, not just in terms of toxicity profile, but also drug levels that are changed as a result of these interactions. And then you may treat some of these diseases because of poor drug levels of either the main drug or because of poor therapeutic efficacy of the antifungal drug if they were having a fungal infection. And that sort of interaction brings more challenges in terms of what's the right strategy to use antifungals for reducing the risk of them happening in these patients, especially in prophylaxis settings. And that again is need more data, and then more work is being done to try and identify how to best manage these infections and the risks for these patients. So in terms of a quick summary on the diagnostics, where we are, and most centers will have easy access to culture and direct methods and microscopy type methods. It's just kind of standard minimum you could do, and if you're lucky, if you grow or isolate in the culture, and then you could look through for high feed, and then that's great, you could diagnose, but often that is a very late presentation. Often patients, if they're growing high feed by that stage, is already disseminated. So really more work is to be done in trying to identify them early at an early sort of angio-invasive phase, or even before they become angio-invasive. And this is where the antigen methods like lactomannan, beta-glucan, lateral flow devices, and then our work in glyotoxin, for example, is showing some direction in terms of how we can screen these patients early and then treat if there is a signal of fungal disease. Similarly, PCRs are now become more streamlined and are now being advocated as of last year as one of the important tests to be included in new diagnostic algorithms for diagnosing fungal disease. And radiology, of course, is available in most centers, but that very much is a subjective technique, is limited by the operator's interpretation of the fungal infection. And if you're not have an expert or experienced radiologist in your center, then you may not necessarily be able to have a clear direction of if this is a fungal disease or not, and you have to rely on other test methods that I've just mentioned to try and help you in that direction. But at the same time, it's important to highlight that we do need also access to therapeutic drug monitoring with azoles, for example, because ultimately we would like to know if they are efficacious or not, if their area under the curve is definitely therapeutic or not. Because if you have a breakthrough infection, if they are under therapeutic, then you clearly know that this is an azole failure because of less or low drug levels, and you could probably switch to a more potent azole for treating them rather than switching class altogether. But if there is a good levels, then you may suggest this could be a resistance pathogens, and then may need to look for resistance screening using PCRs for these infections. And that can give you a clear idea of what sort of therapeutic modality you would like to choose based on these tests that you will have. And the ERTC, as you may know, kind of got together back in 2002 to look for criteria to define fungal disease, and it was revised in 2008, and that has been mostly used in the clinical trials to look for efficacy of various drugs. And then it was again revised just about a year and a half ago in 2019, late 2019, which just before the pandemic, in which it recognized that there is an expanded group of host population. You have to have the right host to have a risk of fungal disease, and that includes prolonged neutropenia, all the mentions that I've just done about immunosuppressive drugs, BTK inhibitors, for example, and they all put you at risk of developing fungal disease. But you have to also have certain clinical radiological criteria matched to potentially call it as a possible fungal disease, for example. But more importantly, mycological tests that will hopefully give you better confidence in calling this as a probable fungal disease. Of course, it can show the hyphae and grown isolate, that's a proven disease, but more or less we are stuck in the serological methods in most centers, or if you're lucky, a PCR-based method that you may be able to access. But that is, again, is patchy. Not everyone has access to these mycological tests, and turnaround times are an issue. So you're really left with a host and a radiological problem that you're trying to define if this is definitely a fungal disease or not. And this is where kind of it's important to understand that if you were to start waiting for applying ERTC defined criteria, in other words, trying to get all those diagnostics tests done, getting the reports through, by that time, the fungal burden has already kind of gone through more difficult phase, disseminated phase, which is much difficult to treat, and even if you throw in targeted therapies, may not necessarily save your patient. So everything that is being done is trying to identify at an early stage, screening these patients before the burden of disease increases again is the key way to improve care for these patients. And I think combination of diagnosis could help in some way in that direction, because if you just use single tests, for example, in our center that was published a few years ago by Dr. Cisse et al., that only 11% patients, if you use a single test, for example, could be identified ante-mortem for potential fungal disease. But if you were to combine all of the tests, including lactomannan, beta-glucan, biopsies, CTs, PCRs, all that together almost doubled the incidence rate of these invasive fungal disease in the same patient group. And that was interesting because clearly we would have otherwise failed to identify patients, in half of these patients, if we just use one test. And because those patients were identified up to 21%, it is quite real life, because if you look at the postmortem series, around 20% of these patients are only diagnosed postmortem. And then clearly, by improving the combination and the better use of diagnostics, we should be able to detect them ante-mortem more early, and hopefully reduce the mortality that otherwise is associated with these proven probable type diseases. And that is kind of what we really need to work on, to try and improve diagnostics so that this curve is more flatter rather than kind of going south. And moving on to kind of from where we are in therapeutics, we all have basically 3 or 4 classes of drugs that are available to us, primarily 3 classes here, which is polyenes, azoles, and echinocandins, and we keep adding different drugs into these classes. More recently, for example, isavuconazole in the azole settings, and then enidulafungin, and even other drugs like risdiplam, for example, is coming along. But these are all just the same class of drugs, which are limited in choice, because if you fail one class of drug, you're left with 2, and if you're intolerant with the other, then you're really left with 1. And that really poses a big challenge in some of these complex infections, which are very difficult to treat for our patients. And it's important to highlight the spectrum of these agents against these pathogens. For example, AmBisome has a quite broad spectrum activity against most of the invasive fungal disease pathogens, including mucorales, including Fusarium, as well as Aspergillus infection, but also Candida infections. If you look at the echinocandins group, for example, it's mainly limited to the Candida group of pathogens, and less so for Aspergillus or any other of the rare pathogens. Azoles, mainly the triazoles, seems to be doing quite better in terms of the overall spectrum of cover, mainly with posa and isavuconazole, and voriconazole has a limited effect on the mucorales, which is its limitation. So it's important to kind of know how the spectrum of cover for each of these agents before we start thinking about how we're going to use one of these drugs for our patients. And it's important to define the strategy you will probably want to take in your center, because you need to know what your epidemiology is in your center. If you're really seeing high-risk patients, you're doing allogeneic CAR T, allogeneic treatments, CAR T patients, all of that will define if you are seeing a high-risk population that you may need to think about prophylaxis or empirical approaches. If you're not seeing as many high-risk or just lower intermediate risk patients, you may get away with using preemptive approaches, but you have to have diagnostics in the middle of it to try and give you that chance to be able to do preemptive approaches. Otherwise, you're stuck with either giving a large amount of prophylaxis to a bulk of large patients, and then an empirical approach for fever-driven strategies. And that is not really ideal, because we often overuse these agents, and that means more toxicity, more morbidity for these patients from a treatment point of view. And that is what the key part is where antifungal stewardship starts coming in, is how we improve that element and move towards some sort of preemptive or focused treatment for these patients using diagnostics. And if you talk about empirical approaches, for example, and a lot of previous studies back in the 80s and going to early 2000s were published looking at different drug models, including conventional amphotericin B, fluconazoles, conventional versus liposomal formulation. And the one I would like to highlight was the key one that was heavily talked about at the time, with the comparison of voriconazole versus liposomal formulation of AmBisome. And then this was a randomized study, and that came back showing some equivalence in the composite endpoints and with variable success in the secondary analysis. Again, this was a questionable study, and I'll show you a little bit why. Because if you look at this sort of table, most of the responses were in favor of liposomal formulation, except the one which is in the second row here, which shows breakthrough infection, was lesser in the voriconazole arm. However, this study failed to meet the defined endpoints. As I said, AmBisome appeared to be superior to voriconazole on all the other endpoints. And even this breakthrough infection, where this voriconazole was shown to be a bit better, was also misquoted according to a later critique published by FDA and Cochrane Review that clearly criticized the study design and how definitions were used for breakthrough infections, definition for voriconazole arm, for example. And that seems to be suggesting that this may not be a correct interpretation of how the efficacy is of voriconazole versus liposomal formulation. And if if you look at within the amphotericin formulations with liposomal versus conventional arm, it clearly on the Cochrane sort of meta-analysis review, and we all know from our experience that liposomal formulation is better tolerated, has less toxicity issues with renal toxicity, for example, and that leads to potentially reduced invasive fungal disease related morbidity with these patients. And that's probably because they are better tolerated and are able to have it for longer compared to the conventional drug, which is often difficult to give, and then they often have to discontinue early on and may not have the desired effect. And if you look at the doses, there's a clear signal that the 10 milligram dose, for example, is not really needed. You really don't add any benefit by using higher doses. 3 milligram per kilogram dose is generally quite good and tends to give you significant similar responses compared to a 10 milligram dose, and you try and avoid toxicity by doing that. But if you look at the empirical approaches, when you compare with the liposomal formulation of amphotericin with caspofungin, and this was done again about 16, 17 years ago now, and this was the only randomized study at the time which compared these two drugs and looked at a large population of 1,100 neutropenic patients post-chemotherapy, for example, and some stem cell transplants. And it definitely showed that there was efficacy for caspofungin with a similar overall response. But if you look in the details, most of the patients included into this study from our current definition were low-risk patients, and clearly suggesting that you may not necessarily could compare the efficacy of caspofungin with the liposomal formulation in the high-risk settings. And this is where IDSA and even subsequently ECIL guidelines have suggested that echinocandins are not effective in the first line or monotherapy of invasive aspergillosis, but can be used as salvage therapy. And then again, where azole and choline antifungals are contraindicated. So clearly, as a second line, it potentially has a role, but not in the first line settings. And if you look at empirical versus preemptive approaches, and this was again a defining study where people felt more comfortable using empirical approaches because it could clearly show that there was a decrease in risk of fungal disease if you were to use an empirical approach versus a preemptive approach. Although you could, preemptive approach definitely had a reduced antifungal use. You were saving some money, reducing from the fungal use, but it led to more morbidity because of more patients were actually developing fungal disease. And this was done in the era when diagnostics were really not well done. And I think things probably are improving since, with better use of diagnostics, and have to rethink this strategy about, just bound or sort of fever-driven strategy from empirical approaches, moving on to some more of preemptive or screening, targeted screening strategy where we can kind of use these antifungals in a bit more judicious manner. And if you look at the treatment elements where patients were treated with proven disease, and this is where voriconazole was successfully able to show that in this randomized study, when they compared to conventional amphotericin B, not the liposomal formulation, conventional amphotericin B, showing a superior survival benefit if you use voriconazole in treating these probable proven disease. However, this again study published about 18-20 years now has been criticized since multiple times in various reviews, as well as Cochrane review, which looked at the detail of the devil really, because the authors handicapped the amphotericin arm in this study by saying that if you were to develop renal toxicity or electrolyte imbalance, you would come off this arm altogether. And that meant only median of 10 days of therapy was given for amphotericin group versus 77 days for voriconazole group. And as you know, the more you can give for a longer period of time, you're likely to have a better outcome for these patients. So maybe for that reason, the voriconazole did manage to show better survival, and amphotericin B patients could not successfully treat fungal disease and then had a poor survival. And this is what seems to be the issue when we start thinking about how voriconazole efficacy is when you compare to amphotericins. But again, this is not compared directly to liposomal formulation, and there is no study ever since been published in a randomized fashion for that. If you look at isavuconazole, which is the new kid in the block, it's a triazole and seems to be quite effective in treating probable proven fungal disease. And it was shown in the SECURE study published a couple of years ago that had non-inferiority to the voriconazole arm, suggesting that it works equally well. And on the plus side, it does not need any therapeutic drug monitoring, which was highlighted by the company at the time. But there are definitely some areas where the therapeutic drug monitoring could be used for these patients with isavuconazole, and that led to ECIL 6 grading it for 1A as a treatment option for patients who have a probable proven disease. And then more recently, just hot off the press, this study was published just last month in Lancet, and this compared posaconazole versus voriconazole in the treatment setting, again, phase 3 study, randomized controlled non-inferiority trial, and it also showed that posaconazole was non-inferior to voriconazole and was better tolerated, as much reduced significant toxicity profile, really suggesting that possibly the days of voriconazole are slowly becoming over, and we do have better drugs in the azole group of the class of antifungals, where we can successfully treat these patients with limited toxicity. And that's something we have to try and think about in our equation of our patients when we think about the algorithm for treating these infections. And then that lets kind of just overall summary of where we are in the therapeutic drug options. We really have the choice between the conventional amphotericin B or liposomal formulations of voriconazole, posaconazole, isavuconazole, or echinocandins. But this is all just based on number of 5 studies that was done as randomized study, and only the more recent one, which I just highlighted, published a month ago. But all the other studies have, been very limited in terms of defining one drug efficacy over the other, and the liposomal formulation has not been really studied in that manner when we compare to the other agents that are currently available. So it's important to think about where do we fit in with these agents in the overall algorithm, because you need to see what your risk profile of your patients are, what sort of diseases you are seeing, resistance in your hospital for azole resistance, for example, toxicity issues, cost, of course, is an important part of that. Can you access these drugs? And all that has to kind of take into account when you start building up your algorithm and define first line, second lines for use of these drugs. And ECIL gives you recommendation for proven probable disease with voriconazole, which again is a flawed study, but been given A1 grading. Isavuconazole on the secure study been given A1 grading. Liposomal formulation is sitting at B1 grading, and based on more retrospective series data rather than a randomized study. So clearly that is a missing gap that hopefully needs to be sorted to look at the true efficacy of the liposomal formulation. And in terms of candidiasis,
1 minute, please.
Yeah, micafungin is any of the echinocandins are similar in efficacy, and you can use either of these agents. It doesn't have any better than the others. And in timeline of the antifungal drugs, we are lucky we've got more drugs coming along in the last decade or so, but increasingly the resistance is increasingly being defined for these agents, mainly because widespread use of these drugs in agriculture, environmental sort of, or industries where these drugs are being used, and leads to more widespread resistance. We are lucky that we are now becoming available some new class of drugs, which is what I mentioned here, risafungin, for example, orotamide inhibitors, and fosmanogenipics. I'm quite excited about the fosmanogenipics because it has a broad spectrum of activity, but orotamide, it can be quite useful in azole-resistant type complex infections, and we're doing studies on these drugs in our center. And it's important just finally to mention that all of that is quite good that we try and getting it better in understanding the type of fungal disease we are facing, the drugs effect from the immunobiologics we're giving on the type of patients we have, but we also have to understand the cost and the resistance of these infections. That will also be a problem for our patients. And this is the resistance map that we can see in the red here, where the resistance is being defined for azole, for example, but the white is where we don't have the data yet. So clearly there is a increasing azole resistance. This was published 2016, 5 years ago. So we certainly have a lot to work for to improve care for these patients. And then finally, just a slide to show our algorithm for our fungal disease management in our patients. We do twice weekly screening for galactomannan. We do baseline CT in our patients for all high-risk categories. If they are febrile persistently, we do drug levels, as well as we request a CT chest. We look for signs of fungal disease in ERTC-defined criteria. If they have, we give them ambisome as a class switch because we use posaconazole as a prophylaxis. So we switch from azole to a polyene in this setting. If the non-specific infiltrates, we request a bronchoscopy, try and define a pathology, and treat in the meantime until we have one way or the other an answer for possible fungal disease or not. If they have no infiltrates and negative biomarkers, then we don't treat and we continue with the prophylaxis model. Of course, if they have a positive biomarkers but negative CT, we may still treat it for a week, but repeat it a week later and then define if we can stop it. So that's kind of how we try and follow as an antifungal stewardship in our center to try and reduce use of antifungal drugs for non-fungal indications. But there is such more work to do to try and improve diagnostics, which hopefully will change how we treat these patients. And with that, I will stop and take questions. Thank you.
Thank you, Dr. Mehran, for an elegant talk. So now we'll have a few questions due to the time. So the first question I have is, an immunocompromised patient, like bone marrow transplant patient, for how long you would give a maintenance antifungal?
You mean prophylaxis antifungal?
For those who are immunocompromised,
Yeah.
So if you have a patient who had a confirmed invasive fungal infection and they are still using an GVHD prophylaxis, for how long you will give them prophylaxis?
Yeah. So one, of course, if you have a defined objective for the risk period, really. So if you can define what your risk period is, if it's neutropenia, if neutrophils are, for example, more than 0.5 and 2 subsequent readings, we tend to stop prophylaxis and go down to fluconazole, for another few weeks until their lymphocyte counts to recover. If they are on immunosuppression, let's say cyclosporin had T depletion as part of the conditioning for transplants, we tend to again use triazoles until the neutrophils have recovered, but then just use fluconazole, for example, up to 3 months. If they have GVHD and they're on steroids or immunosuppression treatment, then we give them posaconazole, because that's where the data is strongest at for using triazoles for prophylaxis model until the GVHD is well controlled and come off the steroids. And that's when we stop the azole prophylaxis and change to fluconazole again. It's just defining the high-risk period for that patient group that you need to treat, and then stop maintenance as that period is over.
Thank you so much. Other question is, before bone marrow transplant, if a patient got discovered with a fungal infection, for how long would you delay the transplant?
Very good question. I think that is something we always have in the back of our minds, because this is where the baseline CT and the risk assessment that we do for our patients. We also have been looking at using Bologna score, for example, to find if they have a previous fungal disease history. Do they have active lung disease of any other kind? Are they significantly neutropenic at the time when they're going for transplant? All that suggests that if you do have a fungal disease, then you would definitely want to consider treating that, and obviously get a diagnostics done by bronchoscopy to understand what sort of bug that might have, if it's Aspergillus or Candida or Fusarium, for example. But delaying transplant very much depends on the risk of the underlying disease and the need for neutrophils. And if you think patients do need healthy neutrophils back in to get through this fungal disease, and there is a high risk of the underlying disease to relapse in the meantime, then we tend to just go ahead with the transplant with use of most effective agent that we have at the time. It usually is a polyene, but sometimes we do also add in a second antifungal, either an azole-based combination for that high-risk period when they are really sick, until neutrophils have recovered, and then we step down to a single agent and then come off to a prophylaxis. But those are the kind of risk areas we have to think about, because as I showed in my study earlier, that they have a very poor survival if they do develop fungal disease post-transplant and they overall don't do well. So if we can try and optimize them before going in, and if there is a time to do that, great. If not, it's potentially a risk benefit in terms of waiting or not, and then maybe dual antifungal approach in these patients may help. Sometimes using granulocytes can be helpful to try and reduce the amount of invasive fungal disease. They have a aspergilloma, for example, but there is again a balance in terms of the risk of HLA sensitization, risk of potential GVHD flare post-transplant. All of that has to be kept in mind. So we try and treat as much as we can before we go in. That's the answer, really.
Thank you so much, Mehran. By this, I would like to conclude day 3 of the annual Saudi Hematology Congress. Special appreciation to all the speakers, as well as the moderators, the organizing committee, the technical team, and at the end, special thanks to the 4,000 attendees who are still with us till now. So stay safe and see you tomorrow.
Thank you.